Dr. Amok, please start.
Yeah. Oh, okay. A very warm welcome and good evening to one and all. I, Dr. Amok Chimote, on behalf of NOGS and ISUOG, welcome you all for the last and final session of this wonderful international certificate and training program in obstetric and gynecological ultrasound under the aegis of ISUOG and NOGS. So that now that we have reached the final leg, it is very difficult to say goodbye. And since it will be another long and grueling session, we would be taking the validatory function first before starting the entire session. So, can I have the slides, please, Thiru?
Video.
So, before we start the validatory function, I'd like to acknowledge the presence of all the dignitaries present for this webinar. And I'd like to invite the President of NOGS, Dr. Vedi Marathe ma'am, to please address the gathering today.
Thank you so much, Amok. A very good evening to all of you, respected dignitaries and my dear trainees. I'm immensely pleased to welcome all of you on the concluding session of the ISUOG Ultrasound BT course conducted by Mediscan System Chennai and Nagpur OBGYN Society. It's the most sought after course which was proved tremendous response we received for the course. I was informed and I'm very happy to share with you all once again that this is the highest ever attendance ISUOG has ever had for the BT course till now. And why wouldn't it be? When we have had such a terrific, outstanding faculty for the course. And when Dr. Suresh sir is at the helm, there is no looking back. Dr. Suresh sir has been our guiding force and has been helping us at each and every step. Nirup, can you mute everyone, please?
Yeah, done.
Yeah, Dr. Suresh sir is our guiding force and has been helping us at each and every step. We are very happy that we could be a small part in his mission to spread knowledge to each and every doctor practicing ultrasound. No wonder he's called the Mahaguru of ultrasound in India. Unfortunately, due to some unavoidable circumstances, our Guru, Dr. Suresh, could not join us today, and he has conveyed his apologies to all of you. Dear friends, this course has been our dream project at Nagpur Obstetric Gynecological Society. I'm very satisfied and contented today as this dream has come true and we could successfully take it forward, and as many as 600 doctors were benefited. We have got tremendous feedback informing us that how the attending doctors have found this course excellent and very useful. My heartfelt thanks to Dr. Jihad, Chairman of BT course, and ISUOG for allowing us to conduct this course. Profound thanks to the entire faculty for accepting our invitation. Your knowledge and experience in this field will be deeply valued. I'm sure the registered doctors are going to be immensely benefited with the faculty of your stature. The biggest gratitude goes out to Dr. Suresh sir. I have never seen a teacher so supreme, yet so humble and so grounded. We have so much to learn from him. I have really no words to thank Dr. Suresh. I also take this opportunity to thank my very hard-working team who put in their not 100% but 200%, 24/7 to make this event a grand success. Last but not the least, I wish to thank all the participants who enrolled in such large numbers. This wasn't possible without all of you. Friends, we have also sent you an email with a feedback form. Please make sure, and this is a request from Dr. Suresh sir, that you all must fill in the feedback and send it back to us so that we can improve further and will help us give you a better workshop next time. So without much ado, I welcome you all once again and thank you all of you from the bottom of my heart. Enjoy this beautiful learning experience. See you all very soon.
Thank you so much, Vedi ma'am. Now we'll be sharing a short video of the webinar and all the people involved in this particular certification course. A long grueling 1 month which has passed like a whoosh, and it was actually a precipitate labor, all the knowledge in one go, and now it has come to a conclusion. So let us go through this small video of an acknowledging all the people involved in this successful program. So now I would like to invite Dr. Rajsi Sengupta ma'am, Honorary Secretary of NOGS, to propose the vote of thanks.
Dr. Rajshri.
Please leave the slide.
Am I audible now?
Yes.
Yes.
That was a wonderful video, Amok, a real good compilation of what all we have gone through. And true enough, a precipitate labor it has been since last 1 month. A barrage of knowledge and education and learning and new experiences. I, Dr. Rajasi Sengupta, Secretary of NOGS, on behalf of NOGS and ISUOG, welcome you all for this last and final session, this wonderful certification training program in obstetrics and gynae ultrasound. Even in this difficult and dark time of COVID waxing and waning over the entire year and more, there has been this beautiful silver lining to this situation. And that started with the inception of the ISUOG basic training course in OBGYN ultrasound to be conducted online so that doctors all over the country could benefit from the comfort of their homes and hospitals and improve their skills and ultimately serve the society in a better way. It has been a beautiful journey which started from the first week of February and almost akin to a pregnancy. Today we are almost near term and ready to be delivered. Why do I say pregnancy? So, like any couple planning pregnancy, we advise them to start with prenatal supplements and plan a pregnancy. Similarly, we would like to thank the course director, Dr. Jihad Chaluhi, for this wonderful course program for the training. I would also like to thank Dr. Suresh sir, the ambassador of ISUOG from India, for taking out time for teaching us in so much detail and explaining even the smallest and trivial of doubts raised by the delegates. It is very rare to get a teacher such as you, sir. Thank you once again. The first trimester of the pregnancy is a very crucial one. We may also face many problems that are faced by the early expectant mother. We too faced a few problems in the beginning of the course, made before registration of the course or getting enrolled after payment and logging in. These first trimester issues were solved to the best of their abilities by the technical support team of ISUOG, and special mention for Ms. Catherine, who was very prompt and efficient to solve all the queries and doubts regarding the registration process. Then, as we entered the second trimester, that is the lecture sessions, many of us had many questions regarding the obstetric ultrasound, right from how to hold a probe to the various steps in a complete OBS and gynae evaluation. All these doubts were expertly and diligently cleared by our eminent international and national faculty, Dr. Titia Cohen, Dr. Reem Abu Rustam, Dr. Shabnam Bobdiwala, Dr. Mala Sibil, Dr. Usha Sahadevan, Dr. Chitra Andrew, Dr. Divya Singh, and Dr. Sudarshan Suresh. Without this esteemed panel of experts managing our second trimester, we would have definitely landed in PIH or GDM. So now entering in the last trimester, gaining all the knowledge of the gurus which was possible because of two very important cogs in the machinery. Our education partner, Mindray, who graciously agreed to see this program through and supporting us in all the technical aspects of this course. And the second one being Conference and the technical support team who managed the whole screening and streaming and recording of this elaborate training course and lent their support whenever in need. We once again thank Mindray and Conference from the bottom of our hearts for ensuring a smooth and zabardast streaming of the course. And now it's time to thank the most important entity of this entire certification course, the baby, that is the delegates who have grown from a small gestation sac to a full-term baby, tiding over all the tests and scans, the dual markers, the quadruple markers, the anomaly scans, correcting and learning and relearning the techniques of ultrasound, and constantly challenging the faculty, the mother, with questions and queries to grow into a healthy baby ready to be delivered. But wait, there's still time for delivery. And to decide the date of delivery, we will have to wait till all of you receive instructions by email by ISUOG confirming the dates of the certificate program from 11th March through 11th April and providing them with a revision page to look at it in the meantime. Some of us may have to wait for a few more days as it will take some time for the ISUOG team to process all the course attendees and add them to the online assessment system. But all delegates will receive another email on 11th March instructing them how to access the assessment on ISUOG Academy online platform and then process for taking the test. You will have 3 attempts of 1 hour to pass the test with a score of 70% or more. On successful completion, you will be asked to complete a short evaluation form and then be able to download your certificate directly from our system and be delivered into the new world of well-informed, well-trained OBGY ultrasound consultants. As ISUOG members, you will then have ongoing access to the ISUOG learning platform where you can explore the other online activities and earn CPD points. As always, if they have any questions or problems, they are more than welcome to contact education emails at ISUOG or Catherine Smith for help with these. Last but not the least, I have to specially mention my team from Nagpur OBGY Society, Dr. Amok Chimote, Dr. Yamini Kare, and Dr. Amir Hatekar, who have worked extremely hard in coordinating right from the conception till now full term in managing the baby as well as the mother. So thank you once again. And a special mention goes for Miss Varalakshmi and Miss Subbalakshmi for managing the pre-test and post-test. We have bothered them a lot with tons of queries and they have been kind enough to try and help troubleshoot each of them. So thank you so much and I welcome you and to the today's academic session of the last day of the course. Thank you.
Thank you for the wonderful vote of thanks, ma'am. So with this, we conclude the valedictory session for this course. And Thiru, can I have the slide, please? Yeah, and let us hear what the educational partner Mindray has to say about today's session.
Hello, very good evening to all of you. It's always a pleasure to be associated with ISUOG. And this is truly a platform for great learning and development with these kind of sessions going on. In fact, for last 1 year, the number of online events have increased in a dramatic way because of pandemic. So it becomes imperative for all of us to support these initiatives to make sure that people around the globe get the right training from the teachers. And I would like to thank Dr. Suresh and Mediscan for this initiative. who has been always supportive. Also, I would like to thank Dr. Vedi Matre from NOGS. Now, what we have seen for so many years, ISUOG has been one of the finest platforms to provide high quality content in terms of educational training, clinical training. And ultrasound has been a predominant part of it. And we are very proud to be part of this. At Mindtree, we are committed to our mission, advance medical technologies to make healthcare more accessible. We are creating customer value with comprehensive solutions and broad portfolios, which includes patient monitoring and life support, in vitro diagnostic, and medical imaging systems. And ultrasound is one of the key components of our entire business. Also, Mindray is committed to develop cutting edge technologies and customer centered solutions. We operate around globe, and we work with top clinicians across top institutions to understand the voice of customers and make sure that we incorporate those features back into our products, and also work with people to make sure they are fully trained. And this is one of those platforms where we would like to educate and train people and support these kind of initiatives. Now, coming from India, I think we fully understand that healthcare delivery system is still a big disconnect in our country. We have almost 70% of healthcare delivery available just to 30% of the population. So it's very incumbent on people like us to make sure that we are part of that cause where that missing population who do not have access to the healthcare, we help to build an infrastructure to make sure those people are also covered in this. And I think these kind of educational platforms will enable us to democratize the healthcare in India. Once again, I want to thank everyone who has been part of this program, this initiative, and we would look forward to again associate with you at any point of time. Thank you so much for this. 2020 has not been a great year because of the pandemic. We wish all of you a wonderful 2021, a healthy 2021, and it's our endeavor to work in that direction as well. With that, I conclude my speech, and thank you.
Thank you, Mr. Ashwini, and thank you, Mindray, for the education partner, for being the education partner for this particular session. There's an important announcement. The yesterday's post test had some technical issues, so yesterday's post test would be posted today after the session is over. The pre-test for today's session has already been closed, and the post test for today's session and yesterday's session will be open after today's session is done. You have already received an email in how to view the recordings, the certification process, the pre-test and the post-test. If you haven't received the email in your inbox, kindly check your spam or your junk mail folder. The recorded lectures will be available for a month, that is till 6th of April 2021. The ISUOG membership, all those who have received, please check your spam, junk inbox folders for the mail from ISUOG. And if you haven't received, you must have already received it by now. Any queries, if at all there are, you can write an email to kssmith@isuog.org. I believe all these instructions have already been dealt with by Dr. Rajsi ma'am. So in case you have any technical issues, you can contact education@isuog.org or ksmith@isuog.org for help in any technical issues. So, moving on ahead, yesterday's session we had a good overview of what an gynec ultrasound is. Today, we will be focusing on each aspect in detail. So to begin with, let us start with the organ where the life actually begins and grows and finally comes into the world. Yes, the uterus, the cervix, the endometrium and the myometrium. For this, I would like to invite Dr. Shabnam ma'am. Dr. Shabnam ma'am is a practicing obstetric and gynecologist in the UK and has research interest focused on improving the care of women with a pregnancy of unknown location and ectopic pregnancy. She has been invited to present at numerous international conferences, been awarded prizes for her work. She has written chapters on this topic in several books and has been successful in securing multiple research grants. She is the lead on gynecology training component of the ISUOG Basic Training Task Force. I invite you, ma'am, for your talk today.
Thank you to the Nagpur ONG Society for the invitation to talk to you today about examining the uterus with a focus on the myometrium as part of your ISUOG Basic Training course. So hopefully by the end of this lecture, you'll be able to recognize the typical ultrasound appearances of both a normal myometrium and then abnormal myometrium. And the key questions we're answering are the typical ultrasound findings in both a normal and abnormal myometrium, and when we might think about referring for a specialist opinion. So if we look at the myometrium before the menopause, this is a very typical appearance. So just to orientate you, we've got a longitudinal or sagittal view of the uterus. Our cervix would be somewhere up here, and the fundus of the uterus is here. And then we've got our midline coming through with a full span of the endometrium here. And this darker area surrounding here is our myometrium. So classically, in a premenopausal patient, this will be uniform. So you can see it's relatively homogeneous. You may see vessels within it. It's a highly vascular structure. And then you can see that the anterior diameter of the myometrium is very similar to the posterior diameter of the myometrium. These are all features consistent with a very normal premenopausal myometrium. A lot of the content that we're going to cover today is also covered in the Musa White Journal consensus statement, the reference of which is shown here. And it's a great reference to look back on for more details once we've gone over this lecture. When we're looking at myometrial pathology, as covered in the Musa consensus statement, common pathologies include fibroids, also known as leiomyomas and adenomyosis, and more rarer pathology includes myometrial calcifications and something called enhanced myometrial vascularity. So the most common myometrial pathology is a myoma or a fibroid, which is defined as a benign tumour of the smooth muscle. And we can here see the FIGO classification system for various fibroids in terms of where they're placed within the uterus. And the reference for that is here. Now, this is very detailed and excellent, but it can be quite confusing to remember all the different factors of it. So when you're starting out scanning, really it's important to remember three main distinctions. So in this FIGO classification, fibroid types 0, 1 and 2 basically denote submucosal fibroids. So the majority of the fibroid is within the endometrial cavity. The second type of fibroids, so FIGO types 3 and 4, are what we call intramural fibroids, where the majority of the bulk of the fibroid is within the myometrium. And then types 5, 6 and 7 are more consistent with subserosal fibroids. So those where the majority of the fibroid is on the outside aspect of the uterus. When we're looking at fibroids on ultrasound scan, it's important that we talk about their echogenicity, whether they have any shadowing and what that looks like, and talk about the vascularity. First of all, if we start off by talking about echogenicity, so this as shown in these three images here, or non-uniform. In uniform echogenicity, this might be hypoechogenic, i.e. the fibroid is of a darker colour compared to the rest of the myometrium. Isoechogenic, so it's the same grayscale colour as the myometrium, or hyperechogenic, so it's a brighter white compared to the rest of the myometrium. And examples of this here, so if we look at uniform hypoechogenic, you can see the fibroid slightly darker. Isoechogenic, it's pretty much the same grayscale colour scale. And then hyperechogenic is much brighter white. When we're looking at non-uniform echogenicity, this might be mixed. So you can see there's some parts which are perhaps the same colour, so a bit isoechogenic, and some parts that are hyperechogenic, so there's little different sections within the fibroid. So this is a classic example of a fibroid with non-uniform echogenicity, which is mixed in nature. It might also be non-uniform with echogenic areas. So what we're getting here is just little small areas rather than big chunks of echogenicity which are different. Or you may have a fibroid that's non-uniform with cystic areas. And we know with cystic fluid, this tends to be hypoechogenic, usually very black, as you can see here. So this is a very classical example of a non-uniform cystic echogenicity appearance of a fibroid. The uniform types are pretty standard and they're likely to be the type of fibroids that you see the most. With the non-uniform types, it can be a little bit tricky to know whether these are normal or abnormal. And certainly when you're starting out scanning, we would recommend that you have a low threshold for specialist referral if there are any atypical features or anything that you're worried about. Then we move on to shadowing. So shadowing in fibroids might be around the edges, so two little spikes as shown here in the schematic image and then here in the ultrasound image. You might have these sort of rays of shadowing as shown here, or you might have one big black block of shadowing as shown here. Now, this is the most annoying type of shadowing, as often what that shadowing does is obscure any other surrounding structures that you're trying to look at in terms of the female reproductive tract. And it's really important to be mindful of that. The ways to get around that, so number one, try and change your settings. So you might want to change the gain and make your image a little bit brighter, just to try and dampen some of the shadowing and see if that helps you see your surrounding structures. The other really important thing is to zoom out, so then you can get a nice, good overview of the pelvis and make sure that there's nothing else striking that you're suddenly missing. Then when we
pause, yeah, there are a few comments that slides are blurred on that end. Can you please check?
It's not our problem, ma'am. The internet is slow from their side.
Okay, fine.
Fine, yeah.
move on to assess a nice, good overview of the pelvis and make sure that there's nothing else striking that you're suddenly missing. Then when we move on to assessing vascularity within the myometrium, so there are two main vessels. There's the arcuate artery, which goes all the way around the periphery, and then off it come various small radial arteries. And this is what it looks like in the sagittal section. And you can see here the arcuate vessels shown very nicely here in this ultrasound image. And in the transverse section, you get a similar view. And it's important to note that the arcuate comes off the uterine artery. this ultrasound image is a very good depiction of the various radial vessels that you may see. And this is all very normal. So this is normal vascularity within the myometrium. When we're looking at vascularity within fibroids, so what also may be entirely normal is having circumferential vascularity, so just around the outside rim of the fibroid, or you might get intralesional vascularity. And this ultrasound image shows both. So there's your circumferential vascularity, and there's your intralesional. This can also be entirely normal. When we're looking at grading vascularity, so in the Musa consensus statement, to aid uniformity, they recommend using colour scores similar to when we're assessing vascularity of ovarian masses. So a score of 1 means no vascularity, 2 minimal, 3 moderate, and 4 a high amount of vascularity. And you can see that coming through the circumferential and intralesional types of vascularity. If we go on to look at video examples of that now, so you can see the sonographer is focusing on their uterus. You've got your cervix with a Nabothean follicle, and then you've got the rest of the uterus here. So there's an obvious fibroid here that they've seen, and they're spanning through the whole uterus. And you see how important that is, because actually there's a second fibroid just there. And that's much harder to see and would have really easily been missed if you hadn't bothered to properly look for it and just focused on this one fibroid here. You can see that the sonographer has placed a little bit of coloured Doppler on, and there is a small, I'd probably say colour score 2, vascularity circumferentially around this fibroid. This is much larger than the other, and I would say that it's uniform in its echogenicity, and I would call that isoechogenic. They're trying to measure the endometrium. They've done it all the way at the top there. I would argue that they probably got it wrong. I imagine the endometrium was further down there. That's okay, we're all learning. And then they go on to measure the fibroid. That's much easier to measure. So this one is, I would describe as uniform hyperechogenic, much better demarcated, much easier to measure. And then you measure fibroids in 3 planes, so you just like everything else. So your length and your AP measurement in the sagittal plane, and your transverse measurement in your transverse plane. It's really important to also, when you're measuring and looking at fibroids within the uterus, to try and determine where their location is. So that first one, that larger one, looked like it was fundal and largely intramural, didn't it? The second one was also intramural, but much closer to the cervix. It looked like it was more in the anterior aspect of the cervix rather than the posterior aspect. And that might have clinical significance depending on what symptoms the patient's presented with, and also what intervention, if any, the clinician is planning. So it's important to think about all of those things when you're looking at a fibroid. If we then move on to our next example. So this is a tricky old uterus, isn't it? So we can see our cervix is somewhere there, and then it's definitely multifibroid. So we've got a small fibroid here, got an enormous fibroid here, haven't we? There's probably another third one over here. But the sonographer is being very sensible and practicing a systematic approach. So what they're first trying to do is determine a midline and find their endometrial thickness. And it's so difficult, but that's probably correct. You can see they put in a question mark as they're not sure. And then they're spanning through, measuring the largest fibroid first. So you can see that's got minimal vascularity, probably a colour score of 2, and a small amount of circumferential vascularity when they put their colour Doppler on. You can see the rays of shadowing that you're getting. And I'd say that's probably a uniform isoechogenic, maybe hyperechogenic fibroid. They've taken their 3 measurements. and label their image. And then they go on to measure their other fibroids too. On to our next example. So you can see how thin that endometrium is. Already we can tell that that's highly likely to be a postmenopausal patient. And we've got a fairly nice view of the sagittal section of our uterus. And can you see in just that view how easy, if you hadn't spanned through the entire uterus, it would have been to miss this fibroid? We didn't see it at all in that first plane. But when we span through, we saw this little fibroid. I'd call that probably non-uniform with a bit of mixed echogenicity, this fibroid here. Small, only about 1 to 1.5 centimetres. Measured in 3 planes, image labelled. And then particularly as this is a postmenopausal patient, it would be sensible to then move on to assess vascularity and also comment on its position. Serial scans are also very important in any patient who you're worried about a fibroid, as benign fibroids do not change rapidly in the way that the fibroid looks or the size it is. But like we said before, if there's ever any concern, always refer on for a specialist opinion. Moving on to the next common type of myometrial pathology, and that's adenomyosis, which is defined as the abnormal presence of endometrial tissue within the myometrium. So there's nothing wrong with the tissue. It's totally normal endometrial tissue, but it's just in the wrong place. It's in the myometrium where it should not be. And these are the 4 main features that you often see when you are looking for adenomyosis on ultrasound scans. And once again, they're covered in the Musa statement referenced at the bottom on the left. The first feature is that you get an enlarged uterus, which may be globally enlarged or often is asymmetrically enlarged. So you can see in that picture here, the anterior aspect of the uterus is much smaller than the posterior aspect, which is much more significantly enlarged. You can often get fan-shaped shadowing coming off the myometrium, which is not a typical feature of a normal myometrium. You may often find myometrial cysts, which are entirely avascular, hypoechogenic structure, which may have a white calcified rim around them, which are very consistent with the diagnosis of adenomyosis. And lastly, you get a very poorly defined endomyometrial border. So when this is really sharp in normal uterus, you might find that the margins are really blurred and fuzzy when you're looking at a woman with adenomyosis. So to go over ultrasound pictures of all of those, so here you can see a globally enlarged uterus. And here you can see an asymmetrically enlarged uterus where the posterior diameter is much larger than the anterior. These are, of course, both anteverted uteruses. You've got your bladder here. In terms of echogenicity, so you get classic fan-shaped shadowing, as you can see here. This uterus is also globally enlarged. That's often called the rain in the forest sign, but I wouldn't bother or worry too much about that. I think fan-shaped shadowing is enough. Then onto myometrial cysts. So you can see that they are black, hypoechogenic, avascular, small structures, usually only a couple of millimeters in diameter. They often have a bit of calcification just around them. This is a very classic feature of adenomyosis. And then finally, you get this distorted endomyometrial junction. So if you remember the previous pictures we had, where you had a lovely line where you could very clearly see, that's where my brighter endometrium is, and that's where my darker myometrium is. Can you see how it's much fuzzier here? This is also very typical of adenomyosis. Then going on to more rare myometrial pathology, which includes myometrial calcifications and enhanced myometrial vascularity. So myometrial calcifications are relatively common in the postmenopausal women. They are entirely avascular. And you see these small, tiny little areas of echo brightness within the myometrium. And this is very typical. So here you've got a sagittal view of a postmenopausal uterus, and there's the transverse view. And these are very typical of myometrial calcifications. Then when we move on to enhanced myometrial vascularity, so this can be either congenital or acquired, and acquired is more common, and acquired is almost exclusively after pregnancy and commonly related to retained products of conception, usually after a miscarriage. And what you tend to get when you put colour Doppler on is just this area of intense vascularity that you get, which is exclusive to the myometrium, hence the term enhanced myometrial vascularity. So in this view here of this retroverted uterus, you can see that you've got the midline coming through, nice thin endometrium, and this vascularity is pretty much entirely within the myometrium. This is a transverse view, and you can see something quite similar. And it tends to be a focal point, which is where the retained products of conception are likely to be. So to summarise, it's really important that we standardise our routine examination of the myometrium, and that we're all using the same terminology and the same language, which is why a lot of this lecture references the Musa consensus statement, which I would highly encourage you to read. When we're going over the examination, so we measure the uterus in our standard way, so longitudinal, AP and transverse measurements. We look at the symmetry of the myometrial walls. So is there any global enlargement or asymmetric enlargement, which would indicate adenomyosis? We look at the echogenicity, and if there are any lesions, we see whether the echogenicity is uniform or non-uniform, and what the different types of echogenicity are. If you look back at the slide we had on describing fibroid echogenicity, we describe any myometrial lesions, whether they're well or ill defined, the number of lesions, what their vascularity is, and we look at those lesions in both the mid-sagittal and transverse plane. And although slightly beyond the scope of this lecture, when you're finding it very difficult to delineate the myometrial structure, 3D ultrasound can often be a helpful adjunct. And in terms of which patients you should refer for a specialist opinion, we recommend those in whom you are uncertain about the diagnosis, especially if you suspect malignancy. It's always better to be safe than sorry. And like we've said in most of our lectures, what we're trying to bring home is that it's really important that we're all using standardized terminology when we're describing ultrasound images. And so that'd be Musa for myometrial pathology, but also just to remind you, the IOTA consensus statement for adnexal lesion, the IETA statement for endometrial or uterine lesions, and the IDEA statement for describing deep infiltrating endometriosis. And when in doubt, please do refer for a second opinion. Thank you.
Thank you, ma'am. That was a wonderful lecture. We have a few questions for you, so we'll be taking them now. The first question is, how to classify cervical fibroid on ultrasound?
It depends on how complicated you want to be about it. So I showed that slide with the FIGO classification, so you could use that. But if you wanted to just keep it simple when you're describing a cervical fibroid on ultrasound, so is it anterior, is it posterior, what's the size, how does it appear, what's its vascularity? I think if you can describe those basic things, then that is likely to be adequate in terms of providing with the clinician with enough information about what they'll recommend in terms of management, if anything, to the patient.
Okay. Are the measurements of myoma very accurate all the time?
No, certainly. I think as with most things in ultrasound, number one, there's operator dependence and how good your scanning machine is. We also know that the shadowing that you can get with fibroids can often obscure their margins. So it can be difficult to fully visualize the complete margins of a fibroid. So yes, there will be some variability in how accurate we are in measuring fibroids. But I think you've got to think about the bigger picture. Is it really important about whether a fibroid is 5.4 versus 5.8 centimeters? Probably not. Is it important about where its location is and whether it's 2 versus 5 centimeters? Yes, that's probably more relevant. So I think we have to be pragmatic.
Okay. Are fibroid always benign?
That's a tricky question. I think the short answer is that yes, but we know that leiomyosarcomas, which are the cancerous form, can look exactly the same on transvaginal ultrasound scan. So there is no distinguishing feature which will let you know whether the mass that you're seeing is cancerous or not. I think the main things to note is that if you're worried about the appearance of a fibroid, the level of its vascularity, or more importantly, if it's certainly changing in size or appearance on consecutive serial ultrasound scans, then have a low threshold for referring on for a specialist opinion.
Right. Whether transabdominal or transvaginal scan is the best way to diagnose a myoma?
It depends on the myoma. So I think when we're doing a pelvic scan, most of us tend to start one way or the other. I tend to prefer to start straight with a transvaginal ultrasound scan. And then if I'm struggling to get adequate views, then I will switch to a transabdominal scan. And by that time, the woman's bladder will hopefully have filled up sufficiently to be able to perform the transabdominal. I think often we use both. And certainly for the fibroids that tend to be more subserosal, it may often be easier to see them, and if they're large, on an abdominal versus a transvaginal scan.
Does acute flexion or S-shape of the cervicoendometrial axis signify adenomyosis?
Not as a diagnostic feature.
Okay. What are the size or measurements above which uterus is to be commented as enlarged or bulky?
Yeah, so we had this question yesterday. There is no set measurement as such. I think if you have a uterus that is full of large fibroids, then it is reasonable to call it bulky, but there is no internationally agreed definition of what bulky means. And then when you have the when I showed the features of an enlarged uterus in adenomyosis, you saw how different that looked from a normal one, whether that was globally or asymmetrically enlarged.
Okay. What is the significance of EMV, endomyometrial vascularity?
Sometimes it can have no significance at all if the woman is asymptomatic, but sometimes we'll or often we'll detect these because a woman comes to us presenting with a long-standing irregular bleeding after a pregnancy, and then we'll do a scan and we'll see this enhanced myometrial vascularity, which may be associated and often is associated with retained products of conception. So I think the relevance depends on the symptoms the woman presents with.
Okay. What is the significance of endomyometrial junction differentiation?
It's one of the 4 main diagnostic features that would make us think a woman has adenomyosis. So you saw in the image I showed in the slide that instead of that nice clear demarcation between the endometrium and the myometrium, we have this fuzzy edge. It's often called budding. We have these little buds that come off the endometrium. So you get this fuzzy, blurry line between the two structures.
Okay. What is the significance of calcification in myometrium?
Very little, more just as a feature that you might see and not to worry too much about it. It's relatively common in the postmenopausal uterus.
Okay. Yeah, just a second. Sometimes it is difficult to get the whole length of the uterus in T-waist. So what should be done in such situations?
So if you span out, obviously, your image entirely and then see whether that helps, but often you may have to switch to a transabdominal ultrasound scan, particularly if you've got a very large, bulky uterus with big fibroids on it.
Yeah. How to differentiate between endomyometrial border abnormality and endometrial malignancy?
I think, generally speaking, your endometrial pathology will be focal. And certainly, if there is any malignancy, it is highly likely to be incredibly vascular. And we've got a talk on the endometrium coming up, which will hopefully provide a bit more information on that.
Yeah. How to differentiate between endomyometrial border abnormality and endometrial? Okay, that's done. Do we also get rainforest sign in fibroid?
I think the rain in the forest sign is just, you know, it's a funny way of describing shadowing. So shadowing is shadowing. I think it's probably unhelpful to call it that. We mentioned it in the lecture because you might find it in books or you know, other resources that you look at. I think the whole point is that you get fan-shaped shadowing, and yes, a fibroid can have fan-shaped shadowing, and adenomyosis can have fan-shaped shadowing. But the difference between the two is that with a fibroid, you'll have the shadowing coming off a, you know, discrete circular lesion.
Right. What are the causes of diffuse inhomogeneity of the myometrium?
I don't think there's no sort of differential diagnosis. I'm not sure what you mean by diffuse it depends on what the inhomogeneousness is. I think all you can do is describe what you see, and then we've demonstrated in the lecture the features that would be leading you towards a diagnosis of either a myoma or adenomyosis.
How do we diagnose if a cyst in the myometrium is a myometrial cyst or vascularity?
Doppler, color Doppler.
How to differentiate between AV malformation and RPOCs?
Yeah, good question. What you'll often find is that the RPOC will very much be a discrete mass, may or may not be vascular, within the endometrial cavity. So it is confined to there because that's where it belongs. If any vascularity extends into the myometrium, then you're thinking about whether there's an arteriovenous malformation. And some people have looked as to whether measuring something called PSV, the peak systolic velocity, which obstetric scanners may be more familiar with, is useful in terms of the diagnosis or trying to treat AVMs, but it's not really that useful. So I think I would just keep it simple.
Right. How to differentiate between small adenomyoma and fibroid? Sometimes it gets very difficult to differentiate between the both.
True. I completely agree. Generally speaking, an adenomyoma will be much more diffuse within the myometrium, so it'll be much harder to determine its borders. Whereas with a fibroid, you'll be able to draw a circle around where you think the fibroid is. That is much harder in adenomyoma. But sometimes, there is a crossover between the two. So I think if you're not sure, just describe what you see on the ultrasound and say, this structure could represent either a myoma or adenomyoma, because clinically it may not matter so much what exactly it is. Just describe what you see.
Is there any differentiating point in a Doppler when we put in on an adenomyoma and a myoma?
Not particularly. I think generally speaking, adenomyomas are less likely to have that discrete circumferential or intralesional vascularity, but it can be variable. So there's no diagnostic obvious difference when you're looking at color Doppler between the two.
Right. Any specific identification points for AV malformation?
The main thing is that you will see a discrete area of unexpectedly intense vascularity within the myometrium. Now, we know that in premenopausal women, there can often be a significant amount of vascularity throughout the myometrium, if you look at the way the arcuate and the radial vessels are. But this will be an obvious sort of discrete lesion. It will be very, very intense when you put color Doppler on, and also we'll have to think about what the history was. So why did the woman come in the first place? Certainly if she's come in with irregular bleeding post-pregnancy or miscarriage, then that's going to consolidate your diagnosis.
Yeah. Is there any significance or is there any dimension after which we can label a vascularity as AV malformation?
There is no diagnostic criteria, if that's what the question is asking. So I think it's very much a description based on what you see and what the history is, as I described in the previous question.
Right. post-LSCS patient with AB malformation, how do we diagnose on ultrasound?
So I think we've covered that point, yeah.
What is the difference between adenomyoma and myometrial cyst?
So a myometrial cyst tends to be much smaller. They tend to be entirely hypoechogenic, so black with a little white rim of hyperechogenicity. So they are much easier to see because of that appearance compared to an adenomyoma, which will be much more diffuse and tends to be larger.
Okay, so next question is about the console and the knobs. What are the two reverse R buttons on the switchboard?
I think it depends on the machine that you're using. So I don't think I can answer that question specifically. And plus, it doesn't relate really to the lecture that I just gave.
Right. I think it is dividing the screen into
Okay.
parts. So I think that is on GE machines.
Okay.
And Excel, there's another question. What is Excel on the switchboard? So again, it is machine specific.
Yeah, I'm sorry, I couldn't comment on that.
Do myometrial cysts have a size in adenomyosis, sometimes more than a centimeter?
Unusual. They tend to be very small, a few millimeters in diameter.
How to distinguish between a focal adenomyoma and myoma?
I think we've covered that already, and that sometimes it's not always that clear.
Irregular endometrial wall in adenomyosis and USG characteristic of carcinoma endometrial. How do we differentiate?
I think we've covered that question already, and the features that we may look for. But I think the take-home message is if you're starting out scanning and if you see something that you feel might be suspicious, then refer on for a specialist opinion.
Right. Is an MRI mandatory for mapping or a 3D scan is better? Fibroid mapping.
Fibroid mapping. I would say that if you use transvaginal and transabdominal ultrasound adequately, you are unlikely to need an MRI to map an ultrasound. I think it depends on what's routine in your country and if the person is going to undergo surgical treatment, what the surgeon prefers preoperatively. A 3D ultrasound is a great adjunct with fibroids because a lot of that difficulty you have in demarcating the fibroid's edge because of shadowing is taken away when you use 3D ultrasound. So certainly personally, that would be my preference over MRI, but I think it depends on where you are.
What is HD flow?
I think that's something that they use in obstetrics. It's not something that I'm familiar with.
Okay. How do you recognize malignant changes in a fibroid?
I think we've covered this.
Yeah. In RPOCs, depending on the thickness, how to decide for conservative management or curettage?
So I don't think you can say from what you see on ultrasound purely whether that will determine how you manage the woman. I think you have to look at what her history is, what her risk factors are, what she wants to do, and what her symptoms are. So how heavy is her bleeding?
Right. How to differentiate between an endometrial polyp and focal thickened endometrium?
So Dr. Nithya will cover that in her lecture on the endometrium. So I think it's just better explained with the slides.
Right. Will RPOCs always have raised vascularity? Absent vascularity, that is the absent vascularity in endometrial mass. Does absent vascularity in endometrial mass rule out RPOC? Good
question. No. So if your retained products of conception are very old, so they've been there for a while for whatever reason, and certainly if they've become a little bit calcified, they may not have very much vascularity at all. And in those kind of women, you may not even have a positive HCG anymore, but the history will denote, she'll often come to you because she'll say, I've not had a period. I'm 2-3 months down the line after my miscarriage and I still haven't had a period. Why? And then you do the scan and you may see a mass that's avascular, little calcified. And because of a history of a recent miscarriage, it might warrant you to consider a diagnosis of retained products of conception. So most of the time they are vascular, but not always.
Right. What is a multi-layer endometrium?
What, sorry?
A multi-layer endometrium.
I think that's relating to a trilaminar endometrium, which is a way that we describe an endometrium, the way it looks just after a period, but that will be covered in the endometrial lecture.
How the adenomyoma vascularity? How does the adenomyoma vascularity look like?
So generally, they tend to be less vascular than fibroids, but it can vary. There is no set criteria.
Okay. What are the ultrasound markers for AVM? I think we have already covered that. Could you show the images of different type of fibroids?
In terms of the echogenicity, we covered that in the lecture. I don't know if you guys will have access to the delegates afterwards, but it's essentially that slide I showed with the 6 different types of echogenicity you get in a fibroid. And you don't actually, sorry, you don't even need the lecture slides for that. If you go to the reference, the Van der Bosch reference that I quoted, which I hope you can provide to the delegates, that is a paper freely available that has all of those pictures and classifications.
Right. What are the USG features of gestational trophoblastic neoplasia or invasive mole?
I think that's a different lecture.
How to diagnose uterine perforation on USG?
Not necessarily always easy. I think you'd go by the clinical picture and the procedure the patient has recently had that would make you worry about perforation. I would not necessarily routinely scan someone if I was worried just purely specifically about a uterine perforation. I think you treat them clinically.
Right. What do you mean by highly congested endometrium post-MTP?
Post what, sorry?
Post-MTP, medical termination of pregnancy.
I've not heard the term highly congested.
Okay. Maybe the delegate wants to ask hypervascular or congested endometrium.
Yeah, I think if you have that post-termination, it's like any other post-pregnancy uterus. So you'd consider whether they either have retained products of conception post-MTOP or whether there's an AVM, an arteriovenous malformation.
Right. In young patients that are non-pregnant, sometimes there can be increased vascularity seen in the myometrium. What does it signify?
I think if it's really uniform, then it's likely to represent normal myometrial vascularity. So in that slide that we showed, you know, the arcuate vessel, which goes all the way around the uterus, and the little radial vessels that come off, traversing from the outer part of the myometrium into the towards the endometrium. So you might just be seeing that, and of course you'd expect a lovely, well vascularized uterus in a premenopausal woman.
Right. Can there be a single cyst present in the myometrium in a normal uterus?
Do they mean myometrial cysts? Yes, potentially, but often there's a little cluster.
Okay. How can we differentiate? Okay, that is in the other lecture. How to suspect AVM in uterus, that is also done. How to measure ET when there is fluid in endometrial cavity?
Yeah, good question. That is also covered in Dr. Nithya's lecture, but essentially very quickly, you minus the diameter of the fluid to give you your true endometrial thickness.
Right. Cystic adenomyosis appearance, how does it look like?
So I think they're referring to the presence of myometrial cysts, which we've discussed.
Right. Specific ultrasound marker for placental site trophoblastic tumor, I think again it's in the other lecture.
And also, I think it's probably a bit more advanced for a basic training course. I think PSTTs are very rare, and no, they probably won't be covered in the other lectures, but I don't think that's relevant to a basic training course.
Right. Ma'am, that is all for the questions in this particular lecture. Thank you for patiently answering all the questions and queries raised by the delegates.
Pleasure.
Thank you again for the lecture.
No problem. Thank you so much.
Thank you, Dr. Shabnam.
Okay, now that we have dealt with the pathologies of the uterus, let us move on to the next topic and cover the other parts of the uterus, and have a detailed examination of the uterus and its parts. I would like to invite Dr. Nitya ma'am. Dr. Nitya ma'am is a graduate from Madras Medical College and a consultant sonologist in Mediscan. She is a trained medical officer in rural areas and State Health Society, Tamil Nadu NRHM project. She has conducted workshops in CUSP in gynec and obstetrics and delivered lectures and conferences in CEV programs. I invite ma'am for her deliberation.
Dr. Nitya, hello. Hello.
Yeah, she's logged in, right?
हाँ मेरा बात भी हुआ उनसे. Can you please call her again?
I'll just call her.
Ma'am, in the meanwhile, there are a few more questions that have popped up. So can we take them with the permission of Dr. Vaidehi ma'am and Dr. Shabnam ma'am?
Yeah, please go ahead if there are more questions. And Dr. Shabnam and Dr. Usha both are here. Dr. Shabnam ma'am is here. Yeah.
So what is a pelvic congestion syndrome?
So some people believe in this, some people don't. It's very controversial. It's essentially the idea that when a woman presents with pelvic pain and you can't find any other reason, on transvaginal ultrasound scan, you might see that her vessels, particularly those coming from the broad ligament, so those that you see laterally, are incredibly prominent. But that is not internationally agreed as a clear diagnosis as a cause for pelvic pain. So I think it remains really controversial. So I certainly wouldn't advocate going around diagnosing that.
Right. So what should be the PRL settings to detect myometrial vascularity?
Yeah, good question. So I think generally speaking, we know that for ovarian masses, we recommend a PRF of 0.6. I think it's reasonable to start at a similar PRF, and then you want to go down on your PRF or up on your PRF, depending on what you're seeing, until you can eliminate background noise and just focus on the vascularity of the lesion of interest.
Hello. Hello.
Right. I believe Dr. Nitya ma'am has logged in again.
Yes, she has actually. Dr.
Hello.
Nitya?
Please unmute yourself, Doctor. Yeah, ma'am. Please unmute yourself on Zoom. Hello. Can you hear me, Dr. Nitya?
Yeah, I'm able to hear.
Yeah.
Able to hear me?
Yes, we can.
Oh, great. Good evening, all. And thank you for the opportunity given by the organizers. So I'll be speaking on cervix and endometrium.
Ma'am, your video is off.
Video
Let
is
it
off.
be. Our internet is slow, so we don't need to start that video.
Okay, yeah.
You will be sharing your screen, or I'll share the screen for.
I've opened my screen already.
No, it's not visible. Can you please reshare your screen? Please share your slides again, ma'am.
Okay. Able to see?
No, not yet.
Okay, 1 second.
There is a share screen button at the bottom, ma'am.
Yeah, I've just done that. Able to see?
It's logging. It's just starting. Yeah, we can see it.
It's visible. Please put it on slideshow mode.
Yeah, I'll do that.
You're on last slide, ma'am, right now.
Is it?
Yeah, okay. Okay, done, ma'am. Please, yeah.
The learning objective would be at the end of the lecture, we'll be able to recognize the typical ultrasound appearance of the normal as well as the abnormalities in the cervix and endometrium. So we'll understand the typical ultrasound features of a normal cervix and endometrium, and also the typical ultrasound features of the abnormalities in the cervix and endometrium, and also to know when to refer for a specialist opinion. So to start with, the scan has to start with the transvaginal, where the probe is kept at the introitus, and here you would see the orientation dot will be here to the patient's right or the left of the screen, wherein you would see the urethra which is entering into the bladder, which is more anterior, wherein the dot is kept, or the probe is kept in a sagittal plane, and then you would be seeing the anterior vaginal wall, and then the vaginal canal, and then the posterior vaginal wall, and then of course the rectum. So this is what we would be. So it is essential that we first start imaging the vagina. So here we would see, you could see the probe is just, as we keep the probe at the introitus, you could see the vagina is just going back, and then you could see the whole cervix and then up till the uterus. And not only that, but also you could see the surrounding organs are freely moving against the vagina and the surrounding structures. So the rectum, and it is essential always to start looking at the vagina when we start the transvaginal ultrasound. So why do we need this? Then it becomes much easier to see the normal structures, so that whenever we come across or encounter with an abnormality, say for example, like an rectovaginal endometriosis or any nodule or any lesion in the vagina, one would be able to pick up the abnormality very easily. So it's always very important that we do this imaging of the vagina first. Then coming to the cervix, how do we look at it? So at the on top of the vagina, you would be seeing the cervix, and here you could see the external lip of the cervix. This is the anterior lip, and this is the posterior lip. So one which is closer to the surface will be the anterior lip, and then you could see the posterior lip, and also we could see the external os, and then the cervical canal, and then the internal os. And once we see this, so that would tell us this is in the mid-sag plane, and from there we would have to slightly slide the probe in the same line. This is a mid-sag view of the cervix, and then we will have to deviate the probe or tilt the probe or move the probe towards the right, and then slowly slide the probe towards the left, so that you may make a complete imaging of the cervix in a long axis. Then make a transverse section, rotate 90-degree anti-clockwise, so that you'll be able to see, and also move the probe or sweep the probe anterior to posterior, so that we'll be imaging the cervix at all levels. What are the cervical lesions we will commonly encounter with? The Nabothian follicle and the cervical polyp, and less commonly the cancer. And what is an endocervical polyp or the cervical polyp? This is mucus filled cyst which is seen on surface of the cervix, caused by squamous epithelium of the ectocervix growing over the columnar epithelium of the endocervix. Here you could see them as tiny cystic lesions over there on the either side of the lip of the cervix. Here you could see that, or it could be either single, multiple, or like clusters over here. And that this tissue growth can block the cervical glands. And what are the features on ultrasound? All these cysts, they appear anechoic because they're all fluid filled, and they are also avascular as shown in this picture. So here you could see the whole mid-sag of the uterus, and then the cervix has been focused, and you could see the cervix, and here you could see the color box has been switched on, and you can see there is no vascularity, and the cervix has been slided towards, you slide the probe towards the right, and then again you slide the probe towards the left, so that you get a good imaging plane of the cervix. Coming to cervical polyps, the polyps could be either sessile or pedunculated, well circumscribed masses within the endocervical canal, as you see over here, and they could be of hyper or hypoechogenicity, and it's essential to identify the stalk attachment, which will help us to locate whether the polyp is attached to the cervical wall, or is it attached to the endometrial, or is it as a stalk communicating with the endometrium. And also it is very essential to look for a feeding vessel, which will help us once again to identify the stalk from where the lesion is arising from. And next, coming to the cervical cancer, it's a heterogeneous mass which involves the cervix. Here you could see the lesion in the cervix. And as we all know, the any malignancy will have increased vascularity on color Doppler. And here ultrasound helps us to evaluate first and foremost the location and the size of the lesion, and also the parametrial invasion, whether the lesion is extending into the vagina or into the adjacent organs, and if so, then we'll have to also look for the evidence of any dilatation in the kidneys, hydronephrosis. So this is a picture where you could see the mid-sag view of the uterus, and you could see the cervix is very well shown in this picture. You could see the, and why is it essential? Because once you see the cervical canal, then further from the endocervical canal, you could trace the endometrium. So here you could see the anterior and posterior wall of the cervix. The endocervix is very well shown, and you could see the mid-sag view of the endometrium in a mid-sag plane. And why is it important? Because this has to be horizontal, that is almost perpendicular to the sound beam. The sound beam is from here, and this should be horizontally placed. So that you'll be seeing the endometrium very well in a mid-sag plane at its maximum thickness. So the normal endometrium will differ between women before and after menopause, and also changes occur through the menstrual cycle. So what are the changes we do expect? This is shortly soon after menstruation, the endometrium appears hyperechoic as a thin line. And here you could see in proliferative phase, it appears hypoechoic, and also this is the triple layer or a multi-layer endometrium or trilaminar. It's been given a different name. So this is the triple layer pattern, which becomes more pronounced in a late proliferative phase or almost in the periovulatory phase. And then due to the secretion of the progesterone, you could see the endometrial picture totally changes into hyperechoic endometrium, which is the secretory phase. And what are the changes that occur during the menstrual cycle? Here you could see these are the pictures which are obtained from the same woman at various phases of menstrual cycle. You could see the endometrium. This is soon after the menstruation, thin endometrium, and in relation you could see the ovary where there are tiny follicles. Then 3 days prior to ovulation in proliferative phase, you could see the 3-line endometrium, and then you could also see a dominant follicle. When would we say dominant follicle? And the follicle is more than 10 millimeter. And here you could see another, it's almost just before ovulation or late proliferative phase, where you could see the endometrium is the triple layers becoming even more thicker, and you could see the follicle becoming bigger. And then you could see here the secretory phase where the endometrium is appearing hyperechoic, and also this you could see the corpus luteum over there, which is having an echogenic rim, and you could see the bands in this. This is very characteristic. This is the corpus luteal system. And on color, it shows a ring of color, which is very characteristic of corpus luteal system. So how to measure endometrial thickness? To measure the endometrial thickness, as I told, the image should be, B mode image should be well optimized, well magnified and optimized, so that you could see the endometrium well in horizontal plane, and you could see up till the fundus, and see at its in the mid-sagittal plane, and then measure the endometrial thickness from the echogenic line to echogenic line at its level of maximum thickness, perpendicular to the long axis of the endometrial canal. And we should make a note not to include the endomyometrial junction, which is a hypoechoic rim which is seen around the endometrium. So how to measure the endometrial thickness when there is intracavitary fluid? When there is intracavitary fluid, you measure the thickness as is shown in this picture, with the fluid in the cavity which appears anechoic. So this is the anterior wall and this is the posterior wall of the endometrial cavity. So the thickness is measured and then summed up and given as the endometrial thickness. And when there is an intracavitary pathology, you measure the total endometrial thickness, including the lesion, unless it's a well-defined myoma that can be measured separately. And what is the thickness, normal or average endometrial measurements throughout the menstrual cycle? So in the menstrual phase, soon after menstruation, the endometrium is thin, which is 2 to 4 millimeter. In early proliferative phase, it's around 4 to 8 mm, and also in the late proliferative, almost up till 8 mm, and in the secretory phase, where it is up to 7 to 14 mm. So this is the normal average measurements. This may vary just few millimeter this way or that way. And here you could see the video clipping of the first to trace the endometrium from the cervical canal, endocervical canal, and then the uterus has been shown and the 3-line endometrium, and it's been shown how to measure at its level in the mid-sagittal plane along the horizontal axis, perpendicular to the axis of the axis of the endometrial cavity, and you could see the endometrium is being measured from this echogenic line to this echogenic line perpendicular to the cavity, and not to include the endomyometrial junction. This is very important. And what is the mean endometrial thickness or the in a postmenopausal woman? As we all know, the in a menopause women, the endometrium will be thin as shown in this picture. So you could see the mean endometrial thickness will be 3 millimeter, and the 10th to 90th centile could be 2 to 5 millimeter, and the endometrial thickness of more than 5 millimeter need not always be pathological if the patient is asymptomatic. So that one should keep in mind that if it is more than 5 millimeter in a postmenopausal woman, it's not always pathological in an asymptomatic woman. So here we could see in this video, so the uterus in mid-sag view, you could see the cervix and then the endometrial endocervical canal and the endometrial cavity well shown in this picture, and then you could see the endometrial thickness being measured in this. So that is how the endometrium is measured. And when the endometrium is being measured, always you slide to the right and then towards to the midline and then to the left in long axis. Then you rotate and make it transverse, and then again you have to go anterior to posterior so that you get a complete evaluation of the endometrium. Then what are the various appearances of the endometrium? This always we compare with that of the surrounding myometrium. So endometrium may appear hypoechoic compared with the surrounding myometrium, or it could be isoechoic, same as that of almost similar to that of myometrium, or it could be hyperechoic compared with that of the myometrium. And coming to the endomyometrial junction. So the endomyometrial junction is the hypoechoic or the dark area which is seen around the endometrial lining, as shown in this line diagram, well appreciated. It could be either regular as seen in this picture, or it could be irregular, like you could see this irregularity, and here also you could see this could be in case of adenomyosis, which is a characteristic feature, and then or it could be interrupted like in this picture in case of either an endometrial polyp or a submucous myoma as shown in this picture. So how to describe the endometrium? If there is fluid in the cavity, the IETA consensus has described if there is fluid in the cavity, you need to see for the how do they describe the intracavitary lesion. That is, any lesion that protrudes into a fluid-filled uterine cavity is known as the intracavitary lesion, and it could be a lesion with a stalk, and then we call it as, which is a lesion protruding into the cavity with a stalk over here. So it could be a pedunculated lesion, or if it's a sessile lesion, you could see as a thickening over there, or it could be tiny blebs like you can see here in the endometrial lining. So these are well brought out when there is fluid-filled uterine cavity. So the endometrial lesions, even there is fluid. So one need to look at the endometrial lesion, whether it is arising from the myometrium or if it is arising from the myometrial surface. So that's very important. And then subjective assessment. How do we assess the extent of the endometrial lesion? This is by percentage of the total endometrial surface involved. For example, you see this lesion over there, which is occupied, which is only involving the less than 25% of the whole of the endometrial surface, and which is well brought out because there is fluid in the cavity. So this is less than 25%. So it is known as localized involvement. Whereas when the endometrial abnormality involves more than 25%, then you would consider it as extended lesion in the endometrial cavity. And next, we have to look at the echogenicity. If it is uniform echogenicity or non-uniform echogenicity, see the non-uniform or uniform echogenicity, and outline of the lesion, if it is smooth and regular or if it is irregular, and then color Doppler. Coming to the degree of protrusion of myoma into the cavity, it's the proportion of a myoma which is protruding into the cavity, which is well brought out either at sonohysterography or when there is pre-existing fluid as shown in this picture. You could appreciate that. So when it is totally intracavitary, graded as 0, or when it is more than 50% intracavitary, graded as grade 1, and then when it is less than 50% and maximum portion of it is in the myometrium, it's grade 2, because this would be difficult for hysteroscopic resection. So the protrusion ratio helps to plan the management. And any lesion, intracavitary lesion, should be measured like any other lesion in 3 perpendicular planes, the length, then width and anteroposterior. In 3 planes it has to be measured. And the most common pathology intracavitary, it could be polyp or submucous myoma or endometrial cancer. So coming to the endometrial polyp, what are the typical ultrasound features we would encounter with? That is, the lesion is hyperechoic and we see a bright edge that is an interface between the lesion and the endometrium. So this bright edge is characteristic when there's a big lesion in the cavity, which tells us that it is an endometrial polyp intracavitary lesion. Or we could see, you can see the endometrium thickening. You could see the endometrial thickening, wherein you could see the tiny cystic areas, which is more characteristic of postmenopausal women. Or endometrium will be having an interrupted midline and the lesion appears hyperechoic, and you see there is no midline is not visible in this area, which tells us there is an intracavitary lesion. And even more characteristic feature, when we switch on color, you could see a feeder vessel which is coursing into the lesion. So this is a video clipping wherein the feeder vessel is coursing from the myometrium into the endometrium, which is well brought out in this video clipping. In this, you could appreciate very well the endometrium, and inside the cavity, there is a lesion. By using the technique of sliding sign, you could see that lesion is moving, telling us, and also the bright edge is brought out because there is minimal, very minimal fluid outlining. So you're able to say, yes, there is an intracavitary lesion, and which we are able to appreciate. So this is freely moving inside the cavity. And coming to submucous myoma, this is a lesion which you see there, which is a solid tumor, and it protrudes into the uterine cavity, and the echogenicity is almost similar to that of the surrounding myometrium. And on color, you could see the ring of color, which is the rim vascularity, which is very characteristic of submucous myoma. Coming to the measurement of the intracavitary fluid, like fluid is measured in 3 perpendicular plane, like we measure anything else. That is the amount of intracavitary fluid, like 3 plane, that is in longitudinal plane, maximum length of the mid sagittal view, and you measure the fluid, And then in a transverse section, again we measure the length of it, anteroposterior, and then the transverse, so that you get the 3 perpendicular diameters. And the amount of cavity fluid is defined by its largest measurement in the sagittal plane. And then the intracavitary fluid is also described as anechoic or ground glass appearance or mixed echogenicity, depending upon the nature of the fluid. Coming to endometrial cancer, what are the typical ultrasound features? Obviously, the endometrium, most of the time, the endometrium appears thick and it is heterogeneous or inhomogeneous in nature. And on color, you could see it is highly vascular and chaotic in appearance. And also, the endomyometrial junction is ill-defined in case of endometrial cancer. How to apply color and power Doppler? To ensure color and power Doppler box includes endometrium with the surrounding myometrium. So the first good B mode magnified image, and then settings are adjusted to ensure maximal sensitivity for blood flow, so that we'll be able to get adequate information. So the ultrasound frequency at least 5 megahertz, and the pulse repetition frequency, that is PRF, is 0.3 to 0.6 kilohertz, and the wall filter should be 30 to 50 hertz, and the color power Doppler gain should be reduced until all color artifacts disappear, so that we'll be able to appreciate the color appropriately. And the color score for the endometrium is a subjective semi-quantitative assessment of the amount of blood flow present. So the Doppler ultrasound examination of endometrium, it is a quantification, a semi-quantitative assessment of the color content. So the color score 1 is absolutely no color within the endometrium. The color score 2 will be very minimal vascularity, and color score 3 will be moderate vascularity. Here there are 1 or 2 vessels wherein you could see some little bit more, and the color score 4 is abundant vascularity. This is more a subjective assessment. So for that we need to have a maximum or the optimal settings for B mode as well as for the Doppler settings. So adjust the settings, maximize the detection of flow, so that why this is important, artifacts should be removed, and pulse repetition frequency should be always at 0.3 to 0.6 kilohertz, and the velocity scale should be always at 3 to 6 centimeter per second. That is ideal. And then the installation of fluid within the cavity helps us to identify the lesion, the nature of the lesion, and also the location of the lesion, and to know what the nature of the lesion, the location of the lesion, and also the size of the lesion can be obtained as shown in this picture. You see a tiny lesion. Here you could see a lesion protruding into the cavity, and here you could see a lesion outlined by the fluid. So you know what is the size of the lesion and the location also. And here you could see this lesion, the nature of it, and also the size of it. Coming to intrauterine synechia, here you could see the cavity is not well delineated, and you could see interrupted endometrium because of the surrounding you could see there is hypoechogenicity or interruption in between, almost like that of the myometrium, which is running a strand of tissue running across. Here you could see over here also in this picture. And when fluid is instilled into the cavity, it is difficult to distend the cavity because of these additions or the synechia, and most of the time they'll be having problems like infertility. Coming to imaging the IUCD, the proper placement of the IUCD or not. So the correct placement is in this picture. You could see it's a mid-sag view of the uterus, wherein you could see the echogenic or hyperechoic linear structure in the cavity with a shadowing behind, which is the vertical limb of the copper IUCD. That is how the characteristic picture of copper IUCD we image on an ultrasound. And here you could see a transvaginal imaging, wherein the same thing is seen as a dot.
Sorry to interrupt, Dr. Nitya. Hello.
Pardon me?
Yeah, hello, doctor. Sorry to interrupt.
Yes.
There is some background noise at your end. Is fan on at your side?
No, fan is off, switched off.
Okay, so any window which is
No, wait 1 second. I'll switch off the AC also.
yeah.
Okay.
Yeah, please continue.
And here you could see this is the longitudinal section and this is the transverse section, and you could see the same thing, cut section of the IUCD with the dense shadowing behind. This is a hormonal IUCD wherein we don't see like a dense structure, but then you see an echogenic dot which is seen at the close to the fundus in the endometrial cavity, and only followed by a dense shadowing behind that tells us that this is the correct placement of the hormonal IUCD in a longitudinal plane, and this is in a transverse section. A 3D plays a role in locating the IUCD, whether it is in correct placement or not. So here you could see very well, this is a coronal view of the uterus, wherein you could see the horizontal limb of the IUCD, and then you could see the vertical limb of it well in place. This is the correct placement of the IUCD. This picture, you could see the IUCD is low. It is almost close to the isthmus and almost extending into the cervix. And here in this also you could see, so that tells us this is a, and rest of the endometrial cavity is imaged up till the fundus. So we know this is a low placed IUCD. So we should use a standardized terminology when we describe the images of endometrium and the uterine cavity, namely using the IETA consensus. And when to refer for specialist opinion, those in whom you are uncertain about the diagnosis, especially if you suspect malignancy, one should refer the, or when in doubt, always refer for the second opinion. Thank you.
Thank you so much, ma'am, for this elaborative and wonderful lecture on the pathologies of the cervix and the endometrium. We have a few questions.
Yes.
Okay. Ma'am, could you please explain what is hycosi and 3D hycosi?
Hycosi. That is, we
Yes,
instill contrast. We instill contrast.
Yes, ma'am.
Contrast into the cavity.
At what? Right.
And then echo vist, I think there are various contrast medias which can be used, and then we assess the endometrial cavity. Echo vist and various brands are there.
Right. And ma'am, your opinion regarding 2D hycosi versus a 3D hycosi?
See, in 3D, you get a coronal view of the uterus. That is the advantage. And you're able to see the ostia and all those things in the coronal view, which is not possible in a 2D ultrasound. That is the benefit.
Right. Right. At what endometrial thickness? Okay, that is for the previous lecture. Can you explain sonosalpingography? What are the recommended solutions to be used? Is there any significance of hemorrhagic Nabothian cyst?
Hemorrhagic Nabothian cyst, not very significant. They are all of no clinical significance. Nabothian cysts are all just retention cyst-like, so they are not significant, clinically significant. And using about the sonosalpingogram, we instill normal saline, which is free of air bubbles, into the endometrial cavity, and then we'll assess the endometrial cavity.
Right.
Transvaginal.
Your opinion regarding use of metrogel for sonosalpingography?
I've not tried.
Okay. Can we detect PID in pelvic USG?
See, this is more a clinical diagnosis. PID is more a clinical diagnosis. But if there are any additional, like you see an adnexal inflammatory mass, which is related to ovary or the tubal, then you could relate it to the PI clinical scenario, inflammatory pathology.
Any significance of adnexal congestion to diagnose PID?
See, this adnexal varicosities, even normally we tend to see in some of the reproductive age group. So I think it is not very this thing. Not very
how can we
significant.
right? How can we differentiate between a uterine septum and a bicornuate uterus? And can
Uterine
you please
septum
show some images?
images. I have to go this thing. See, I explain it. Then might be if I have, because it's in my other laptop, I'll not be able to share. And the thing is, like, to first of all, to differentiate between biconvate and a septate uterus, the biconvate uterus has a external indentation at the fundus. That is, at the serosa, there is an indentation because of the failure of fusion of the contour. It's a horns. Whereas in septate uterus, the external contour of the uterus is smooth. It's only the cavities which are bifurcated because of the failure of fusion of the septum.
Right. Uh, what is the significance of thick endometrium soon after menstruation?
That means there is improper shedding of the endometrium, or if the patient is continuously bleeding, then the endometrium might be thick, or if there is some endometrial pathology, even then they could be significant soon after menstruation.
Dr. Suresh sir has commented hycosi is hysterosalpingo contrast sonography in regarding the question asked previously.
Yes.
I'm better.
Dr. Suresh sir is there.
Remdesivir injection I've taken. So,
Dr. Suresh sir, you're audible. Suresh sir?
I think Amok, by mistake, he must have unmuted. You go ahead.
Right. Okay. Occasionally, an endometrium is seen as echogenic midline tissue, yield very little tissue in curettage. Why are we deceived to describe this as a thick echogenic endometrium? Okay.
No, please repeat the
This question, the question, ma'am, is slightly, it's still confusing. I'll get back to you, ma'am, about this.
Yeah.
IUCD embedded myometrium, how will it look on USG?
On ultrasound, as I told you, the correct placement of IUCD will not be seen on in the cavity. So in that case, you have to explore the surrounding area. So in the myometrium, if you see an echodense area that is typical picture of IUCD, then we should think of the possibility of it's getting embedded, and the 3D will be more helpful to suspect such a picture.
Right, that was the next question. Is an X-ray abdomen better or a 3D ultrasound to confirm
3D. If it is within the uterus, obviously the 3D will be more beneficial.
Right. Could you please repeat the explanation of the hormonal IUCD?
Hormonal IUCD doesn't throw bright shadow like copper IUCD. So we'll be seeing only the dense shadowing behind from the endometrial cavity, which would tell us that the IUCD is in position or not.
How can we diagnose the misplaced IUCD that has gone extrauterine?
That has gone extrauterine. If it is not in the endometrial cavity, we could see if it is displaced or embedded in the myometrium, or if it is even perforating partly in the myometrium and outside, we can make out on ultrasound. But if it is outside, then I think X-ray would be more informative.
In a case of incomplete abortion, will we consider the thickness or echogenicity for further management?
It's also it's more the echo texture of the endometrium, which will appear heterogeneous. Though there are many literature which says about the thickness and all, but still they would always say the nature of the endometrium echo texture, and also the clinical picture, what the patient presents with irregular bleeding and all those things. Then we would suspect in favor of incomplete abortion.
Right. Can follow-up of endometrial thickness by USG in a woman with LNG IUS system inserted for simple hyperplasia be done?
Pardon me, please repeat.
Can we measure the endometrial thickness in a woman in whom the LNG IUS system is inserted?
Yes. You can, endometrial thickness. See, it becomes difficult to see when there is an IUCD in the endometrial. when there is something in the endometrial cavity, it becomes difficult to assess the thickness of the endometrium.
Right, right. How to see the uterus in coronal plane using 2D or grayscale? That is
In
B-mode.
2D, it is not possible. 3D, in 3D only it is possible to see the coronal view of the uterus.
Any significance of dextro or levo rotation of the uterus?
Normally we have to see the uterus whether in mid-sag, like how the techniques have been demonstrated. So when you don't see this and you see something abnormal from this, then you suspect the deviation from the normal picture.
Right. What is the significance of multicystic endometrium?
Multi? Please repeat the
Multicystic endometrium.
Multicystic endometrium could be a diffuse.
Significance of multicystic.
Yeah. See, it could be just an endometrial hyperplasia, cystoglandular hyperplasia, or just a simple endometrial hyperplasia, or it could be a diffuse endometrial polyp also, in case of postmenopausal.
Right. Right. Could you please explain the intrauterine adhesion, the picture on ultrasound?
On ultrasound, the endometrium appears irregular, thin, irregular. You don't see the normal appearance or the normal picture of the endometrium like we see in all the various phases. It will be thin and irregular in contour and interrupted also because of these adhesions. And at times even we do see some fibrosis and calcification or bright specks in the cavity. And on attempting to instill fluid, it's difficult to distend the cavity. These are the features. And also a 3D plays a role in, once again, 3D plays a role in diagnosing this. Like you'll be able to appreciate all these features very well by 3D.
Definitely, ma'am. Any role of color in diagnosing intrauterine adhesion?
Less likely.
Okay. What is endometrial hyperplasia and what thickness is called hyperplasia?
See, as I showed in the slide, the secretory phase is the ultimate of the menstrual cycle, where we see up till 14. Though the literature says up till 16 millimeter in secretory phase in a reproductive woman is said to be normal. So anything that is beyond that is considered as thickened endometrium.
What is a 5-line endometrium?
5-line endometrium is nothing but the basal layer, the functional layer, the endometrial cavity, again the functional layer and the basal layer. The triple line is considered otherwise as 5-layer or multi-layer.
Right, right. To instill saline in cavity, we use pediatric Foley's. It was not seen in images. Which is the other method that can be used to instill the fluid?
Instill the fluid, just an infant feeding tube would be enough to assess the endometrial cavity.
What is the volume of fluid that has to be instilled for sonosalpingography?
For sonosalpingography, I think around 10 ml, 10 or 15, depending upon how effectively we are going to do, because the more we instill, the patient is going to have pain and that.
Right, right. IUCD embedded in myometrium, how to go through TVS?
Same like doing a routine pelvic examination. We have to assess the endometrium and the myometrium in a longitudinal plane and sweep the probe from the midline towards the right and then come to the midline and then towards the left, first in a mid-sagittal plane, towards the right, towards the left. Then you rotate the probe anti-clockwise and then rotate the sweep the probe again anterior to posterior, so that you'll be covering at all levels the uterus, so that you'll be able to make out where exactly the IUCD is embedded in the myometrium, whether it's to the right or to the left,
right,
whether it is at fundus or in the lower down.
Right. How to differentiate Nabothian cysts from multiple Nabothian cysts from endocervical cancer?
Endocervical cancer, you'll be seeing a lesion within the canal as well as extending into the lips of the cervix, and they are heterogeneous in nature. the lesion is more heterogeneous or hyperechoic in nature. And on switching on color, you see abundant vascularity in case of cervical lesions, where malignancy, whereas in case of Neviothian cyst, it is totally avascular and anechoic only.
Okay. How to differentiate between hematocolpos due to transverse vaginal septum and imperforate hymen?
That's very difficult. You can do an introital scan, place the probe at the introitus, and we have to look for the evidence of whether we are able to see any septum or so.
Is a feeding vessel always seen in an endometrial polyp?
Yes, yes. With optimal.
On probe temperature.
Tell me, yes.
Yes, ma'am. Please continue.
The feeding vessel is one of the high indicative pointer for endometrial polyp. So always a feeder vessel will be highly sensitive to diagnose an endometrial polyp.
Right. In case of probe tenderness, what is the significance and should it be practiced regularly?
Yes, the probe tenderness, yes, because whenever we do a transvaginal, the patient complains of any tenderness, and that site has to be closely looked into. And I think my earlier speakers have demonstrated about the sliding sign also, which will help us to say about the mobility of the surrounding organs. And also if the sliding sign is negative, it tells us about the fixity. So especially when we come across with endometriosis and all those things, you'll see the tenderness when we look at that site where some pathology we can pick up, like endometriosis or corpus luteal cyst, where the patient has just ruptured the follicle.
Yes. Right. Is there any cutoff for normal endometrial thickness post medical termination of pregnancy?
There is no definite. You see, like soon after the menstruation, you see a thin line. Same way post-abortal, you should see a thin line, or sometimes we do see 3 line, like you see in the early proliferative phase. Then you know it's a normal endometrium.
Right. If we are suspecting an endometrial pathology, which phase of menstrual cycle should the ultrasound be done?
I think soon after menstruation would be ideal, because especially when you're suspecting polyp and all those things. And if you want to look at uterine anomalies, then secretory phase would be ideal.
Right. How to differentiate arcuate and septate uterus on grayscale?
This is a question which is always a bit tough, especially, see, identifying complete septates is much easier because you're going to see the 2 cavities, which is almost extending up to the internal os. But it's the difficulty between the arcuate and the subseptate. And now the arcuate is almost classified as normal, considered as a normal uterus, but still the CUME article gives a beautiful description, like various measurements are given, like how you differentiate between the arcuate and the subseptate uterus. It's an article very well explaining about how to differentiate between those 2.
Right. Significance of fluid in endometrial cavity in postmenopausal women.
Pardon me? Difficulty of? Pardon?
Significance of fluid in endometrial cavity in a postmenopausal woman.
See, in postmenopausal women, we do see minimal fluid in the uterine cavity most of the time, which is not significant. But if there is fluid and the patient complains of there is some purulent discharge or bloodstained discharge, then it becomes significant. Very thin, minimal fluid is not significant.
Could you show or recommend where can we find videos to do hypoxia?
Hypoxia, Google. Must be there are videos in the Google to see how to perform the procedure.
Right. Post tamoxifen endometrial thickness reliability, is it advisable to do routine follow-up by USG after tamoxifen?
Yes, we need to do.
Right.
Serially. Yes, we need to serially monitor them.
Right. thick echogenic endometrium sometimes yield very little endometrium on curettage. What is the reason and significance?
Depends on which phase we are doing, and also sometimes the hyperplastic, if it's a diffuse polyp, sometimes they try to curettage and only a small portion of the tissue comes, but still you see the lesion is there inside. So that could, then we should think of the alternative, diffuse polyp also.
Patient on medical abortion, when we can say it is complete abortion, as in after a surgical or a medical abortion, what is the post-abortion scan findings that can confirm the complete abortion?
As I told earlier, the endometrium, if it appears thin, or if you see a triple line, as you see in the early proliferative phase, or just a 3-line endometrium, then you pretty well, we know that it's a complete abortion.
How easy is it to master 3D ultrasound?
You need to undergo training for the 3D ultrasound because we need to understand the steps. So like 2D ultrasound, you need to have a systematic approach to do the 3D ultrasound.
Right. Okay. How to diagnose uterine torsion in USG?
No idea. I have not come across one uterine torsion.
Okay, ma'am.
Might be it's more a clinical scenario, and when you don't see the things in its place, and
Right.
when the normal anatomy is altered, and with the clinical scenario might be.
Maybe they must be asking regarding the rotation of the uterus, maybe because of the adhesions.
Yes.
Instead of that, not the torsion, but the rotation, dextro or levo rotation,
Or
depending
due
on
to
where the
additions,
pathology is.
mostly it is deflected more to the right or to the left, or sometimes it's attached close to the anterior abdominal wall. So these are the things that due to the additions could be. But rotation, I don't know. Okay.
How to diagnose the follicle is going to rupture? Is it if it is going to rupture with a Doppler?
Actually, a dominant follicle would show a very good neovasculogenesis, like ring of fire, like you see a peripheral vascularity. And we all know what is the optimal size for it to rupture. So that's when we can anticipate. And also in relation to the endometrial thickening, where the late proliferative phase, I showed a nice 3-layered endometrium. They all go hand in hand prior to rupture.
Can the granulosa cell or corona radiata seen in an ultrasound?
You see a corpus luteum, when the follicle ruptures, we do see a follicle which ruptures, and then it can have varied phase. I think Dr.
Dr. Nitya's internet is unstable now.
Okay, I thought mine was.
Dr. Nitya, I think she dropped out.
There is some audio from a window, but we can't see her, can't hear her well.
Yeah, Dr. Vaidhi, can you please contact her?
Yeah, I will call her. Yeah, she's there.
Hello, Dr. Nitya. Hello, Doctor. Dr. Nitya. Hello. Hello. Hello.
I will call her.
Yes.
Hello, can you hear me, Dr. Nitya?
Yeah, I'm able to hear.
Yeah. Dr. Amog, please continue.
Yeah. Okay. How do we differentiate between a pedunculated fibroid and an endometrial polyp?
Fibroid has a characteristic feature where you see the fibroid appearing well circumscribed and more hypoechoic in nature, whereas endometrial polyp is more likely to be hyperechoic in nature. And we'll be seeing the stalk attachment, especially when there is minimal intracavitary fluid outlying.
Right. What are the features of Mullerian duct agenesis?
Mullerian duct agenesis, there are varied features like you can have absent uterus, or you can have rudimentary uterus, or you can see just a small Mullerian derivative. There are various features which we can pick up on ultrasound: absence, or smaller than normal, or undersized, or what we call as hypoplastic uterus.
Right. Ma'am, next question is, can we comment on endometrial thickness with the Mirena in situ?
Mirena in situ, actually, when there is something in the cavity, it is not, it is a bit this thing, but yes, still you can try to lose the Mirena and then try to see, but it would not be an accurate measurement of the endometrium.
Right. What is the ideal time to do a USG for AUB?
Ideal time for AUB is if the patient stops bleeding and immediately soon after the bleeding stops, it would be ideal to assess the endometrium.
Okay. If we notice fluid collection in POD, does it suggest PID?
I think already we have answered. It's not minimal fluid in the PID is seen in the the fluid in the POD is normally seen in a reproductive age group. So it cannot be the diagnostic factor for PID unless otherwise it is significantly seen extending to utrovesical pouch or to the adnexia and all. Then outside the POD, then it might be significant.
Right. How to detect bladder adhesions after previous LSCS?
Bladder adhesions. So you see the uterus by doing the sliding sign, you see whether the bladder and the uterus is sliding against each other. If there is a sliding sign is negative, then you think of the possibility of adhesion.
Right. Ma'am, could you please repeat the name of the article for subseptate and arcuate uterus?
It is CUME. Congenital ultrasound by medical experts.
Okay. Endometrial features to be altered at post-tamoxifen if patient is asymptomatic.
Please repeat the question.
The question is not correctly phrased. I believe the participant wants to ask, what are the endometrial features that are altered after the patient is on tamoxifen?
It can have any of the varied feature which we have shown to already in the picture. I've shown the endometrial thickness. It could be present as a heterogeneous, just a mere endometrial thickening, or it can be like a hyperplastic endometrium, or it can be a polypoidal or so.
Right, right. How to measure, that is done. Difference between dominant follicle and simple ovarian cyst.
Dominant follicle is what you keep serially. You have to serially monitor the follicle. Then we will know that that's a dominant follicle. And it is a simple cyst. If the follicle fails to rupture and keeps growing, then you consider it could be possibly a cyst. It depends upon how serially you monitor the patient.
Right. What are the sonological features of postpartum inversion of uterus?
Postpartum involution?
Yeah, involution.
Involution?
No, inversion.
Inversion of the uterus? No idea.
Okay. How do we define an infantile uterus or a hypoplastic uterus?
See, the infantile uterus, the corpus cervix ratio, the cervix is more pronounced or double the size of that of the uterus in infantile. Whereas in hypoplastic uterus, we consider it as hypoplastic considering your age. When you feel the size is well below the normal size and non-functioning, then we consider it under with a very thin endometrium and not responding to hormones, then obviously they consider it as hypoplastic uterus.
Right. Ma'am, that's it for the questions in this particular lecture. Tirup, can I have the slide for the announcement, please? The next one, please. Yeah, sorry, the previous one. I'm really sorry. Yes. So all of you would be receiving a mail from ISUOG on how to view the recordings of all the lectures that I've covered in this course, the process of certification, that is taking the exam, and the pre-test and the post-test. If you haven't received the mail in your inbox, kindly check your spam folder or junk folder for the same. The recorded lectures will be available for 1 month, that is till 6th of April 2021. ISUOG membership, please check your spam junk inbox for the mail from ISUOG. You may receive it till 24th Feb, so you might have already received it. For any queries, you can write to ksmith@isuog.org. On 5th March, that is today, you will receive an email from ISUOG confirming the date of the certificate program, that is from 11th March to 11th of April, and providing you with the revision page to look at it in the meantime. It will take some time for the ISUOG team to process all course attendees and then add them to the online assessment system. So, in case your name hasn't been added or it is not being reflected, please do not panic. It will be done in due course of time till 11th of March, and if it has not been done, you can contact the technical support team for the same. For the exam, you will have 3 attempts, and each attempt will be for 1 hour, and a pass score of 70% or more is required to successfully complete the certification course. After this completion of the course, you will get a short evaluation form and will then be allowed to download your certificate directly from the ISUOG system. All the ISUOG members will then have ongoing access to the ISUOG learning platform, and then you can explore other online activities and earn CPD points. So in case of any technical support, you can contact on the email ID mentioned below. You can take a screenshot of this particular slide so that you have the email IDs with you at all times. So we move on to the last lecture of the course. And now that we have learned about how to do a gynae ultrasound, how to check for pathologies, what is a normal finding, what is an abnormal finding, it is important as well to pen down your findings in a proper and a chronological and a logical order. For this, the next lecture is the writing of the gynecological ultrasound report, and I request Dr. Nitya ma'am to continue with this lecture. Thank you, ma'am. Dr. Nitya?
Yeah, I'm sharing.
Please put it on slideshow mode.
Yeah, exactly. I'm just doing it.
Yes, please go on, ma'am.
Yes, one second. Oh, F5 adla. It open avladra. 1 second. Open.
Go to view. Go to view.
View.
View on top.
View on top.
Go to view on top. View. You see the view. Yes.
View.
Up. Yeah.
The stuck.
Okay. Click that.
It's getting stuck.
From slideshow also you can do, ma'am, and there is a option at bottom.
1 second. Yeah.
Slideshow. Now we are on slideshow. Escape. Now you put slideshow. Now you put slideshow. Click on the first slide and put slideshow.
It's getting stuck.
Right.
Sorry for that hitch.
Yeah, please continue, ma'am.
Yeah. So the learning objective is going to be at the end of the lecture. You'll be able to write a clear, concise, and accurate gynecology ultrasound report. To understand the importance of writing a good gynecology ultrasound report, and also to understand the basic principles of ultrasound reporting. And what are the key features of the gynecology ultrasound report, and how can I make sure I write a good report? So why is it so important? First and foremost, it's a medical legal document where we need to be very precise in our reporting. And it's a primary means of communication between the person performing the ultrasound, the referring clinician, and the patient. And also it constitutes a clinical opinion of a specialist interpretation of the images. And the aim is to answer the original clinical question and provide information for which would help in further patient management. So the reporting should be accurate, clear, concise, and logical. So before the examination, what is the clinical question? So we need to get a detailed history from the patient so that we'll know what is that is expected to be seen in this patient. And during the examination, one need to specify the observations, what has been seen. Like say, for example, we do a sliding sign, we look for any mobility or fixity of the lesion. All those things need to be highlighted. And or if we come across a case of say torsion ovary, where we're looking for the whirlpool sign, those things need to be, the additional observations need to be highlighted. And after the examination, we need to come to a final judgment or a conclusion and a final diagnosis. And at times when we are not sure, might be we do give or when there are possibility of an alternative diagnosis, we do entertain a differential diagnosis. So the basic guidelines for a gynec report, it should be written and issued by the sonologist. The person performing the examination should issue the report, and it's an integral part of the entire examination. Should be written as soon as possible after the examination is complete, and sonologist is fully responsible for the accuracy and content and should be aware of their limitations and seek advice wherever necessary. And it should be mostly printed. If it is handwritten, a blacking should be used, and the report should be appropriately dated, signed with the reporter's name and designation, and filed in medical records. And use of a pre-existing template or an electronic database will help us to maintain the consistency of reporting, also allows research and audit to take place, and ensures adherence to local standards. So an example, so from this, we could see here it tells primary, some name, you could see something scribbled over there where the handwriting is not even legible. And a normal uterus, it tells normal uterus, ovaries normal, complex mass next to the right ovary, and scribbling of the operator's name. So we don't have, it's written in blacking, that's the only thing fulfilled in this, but we don't have the patient's name, the age, the date when it was done, and there is no precise description of what is the size of the uterus. All those details are not given. So the size of the uterus and size of the ovaries and the nature of the mass and what type of mass, nothing is being described in this, and no final impression. So these are some of the softwares wherein when you go systematically, you try to fill in these details. There will be a systematic approach wherein the uterus, whether it is in normal position or it is deflected to one side, whether it is freely mobile, in long axis, what is the measurement, transverse axis, the volume, then the length of the cavity, then if there is any uterine anomaly suspected, then visualization, whether endometrium is first of all visualized or not, and the total thickness, and then endometrial midline, all these features, if we go one by one, so that we'll not miss any of these features. Then we'll make a complete report. Also coming to the myometrium. So we first uterus, then look at the endometrium, then coming to the myometrium, then coming to the cervix, and finally to the ovaries. So one will be able to complete a gynecological report. So the report should be clear and concise, use present tense, easily understood, using standardized terminology, and avoid technical jargons. Abbreviations should only be used when standard, and any actions or recommendations should be clearly reported, and a succinct conclusion should be included, and a report should be conclusive wherever possible and indicate whether the appearances are consistent with the specific diagnosis. Say, for example, we see a endometriotic cyst. We describe the cyst, so we say these features are consistent with endometriotic cyst. Or say, for example, a dermoid cyst, where we see an amorphous material in the ovary, so we say yes, these features are consistent with. Or you see a mass lesion which is heterogeneous and highly vascular, which is more compatible with the malignant lesion. So that is how we need to come to a final conclusion. So where this is not possible, then an alternative explanation or a differential diagnosis can be offered. So the summary of the report should have a clinical history. So a detailed clinical history is a must, and the structures, what are the structures examined, description of the findings, interpretation of the findings, and the conclusion finally. So this is a patient where they have, what are the details of the reporting format? Patient's detail, the name, the surname, the date of birth, that is the age of the patient, sonologist who performs, name of the chaperone when present, and especially if it's a male who's doing, and obviously a chaperone there, and the place of a scan, where it is performed, type of the machine, the model, the probe features, and then the examination method, by what route we are performing, whether it's transvaginal, transrectal, or transabdominal, and then the indication for the scan, and whether for what complaint, whether it's abnormal uterine bleeding or any intermenstrual spotting or whatever it is, and any limitations, like whenever we come across with body habitus or multiple scars in the abdomen, by which you see there is attenuation or limited, or when there is overlaying gas or limitation in imaging, that should be highlighted in the report. And the basic history should include the LMP, the length of the menstrual cycle, whether the patient is pregnant or not, what is the parity, and if she is in the menopause status, or whether there is contraception or HRT use. And also examination of the uterus, orientation, whether like Dr. Shabnam had explained about the version, flexion of the uterus. So that orientation, whether it's anteverted uterus or retroverted uterus, and then the position, whether it's in the midline or deviated to the right or to the left, and then the size of the, whether a longitudinal section or transverse, and then the size of the length of the entire uterus, largest anteroposterior diameter of the corpus of the uterus, and largest transverse diameter of the corpus of the uterus, and then the size, general echo texture or the echo pattern, shape of the uterus, if it is, whether there is any altered shape like globular or irregular, when there are multiple fibroids which are altering the contour, or globular like we come across in case of adenomyosis, or the extra, and then mobility or the sliding sign, whether there are two, which would tell us whether there is fixity or free mobility of the structures. And whenever we image the endometrium, most important is the assessment whether it is visible, whether the endometrium is visible, whether the endometrium is not visible, or if it is accessible or not accessible. And if it is not accessible, one need to highlight that in the report, especially in postmenopausal women. Sometimes it becomes difficult, or when there are large fibroids, or in case of adenomyosis, the endometrium imaging might become difficult. And when it is not accessible, one need to highlight that, or the difficulty or the limitation we come across because of the position, the version, flexion, and because of presence of the pathologies, as I told. And then the thickness or the appearance, that is synchronous with the menstrual period or the postmenopausal status, or whether on medical treatment. And then endomyometrial junction, whether it's smooth or irregular, regular, irregular, or interrupted, or not accessible. And then focal pathologies like fibroid or polyp or other. Coming to the myometrium, Overall myometrial echogenicity has to be defined whether it is uniformly homogeneous or heterogeneous, like we come across in case of adenomyosis, or whether there is any diffuse or focal pathology like a fibroid or adenomyosis, and also the size of the lesion if it's a fibroid, and the location of the lesion if it is a fibroid, whether it is in the upper uterine corpus, mid uterine corpus, or lower uterine corpus, or whether it is to the right or to the left, or whether it is close to the cavity or it is close to the serosa. All this information have to be highlighted. And then the cervix, if it is normal, usually it is not mentioned, but one need to have a detailed imaging of the cervix. And then any abnormalities noted in the endometrium or myometrium, we should always follow the IETA and NUSA terminologies to make it a very systematic reporting. And examining the ovaries and adnexa, both adnexa must be examined, and size of both ovaries should be measured in 3 orthogonal planes. Number and pattern of the follicles where present. Phase of, especially if a woman is coming for infertility workup, one need to give the correlate with the phase of the menstrual cycle, and can highlight about whether she's in the proliferative phase, what is the feature we are seeing on ultrasound in relation to endometrial cavity and the follicles in the ovary, or if it's in the periovulatory phase or in the secretory phase. So the endometrial and as well as the ovarian picture or the imaging pattern can be highlighted. And then coming to the mobility, yes, we need to see whether the uterus or the ovary is freely mobile, or there is reduced mobility, or there is fixity, that is what we call as the sliding sign. So by this procedure is done by slightly applying pressure of the probe towards the uterus, and then suprapubically you give slight pressure so that you can see the structures moving independent. When they move independent of each other, then you know it is freely mobile, or when it is slightly reduced, or when it is fixed, the whole thing moves as a whole. Either the fixity could be due to the uterus, to the adjacent bowel, like in deep infiltrating endometriosis, or it can be even adherent to the pelvic side wall. These can be appreciated either to the ovary or to the adnexal mass. These can be well demonstrated, and it has to be reported. Then tenderness on pressure, yes, probe tenderness. So one need to give more attention to the probe tenderness, especially in case of deep infiltrating endometriosis, or so when the bowel is involved, or when there is in the POD there is tenderness. One can concentrate on that area and look for any pathology, and that can be highlighted. Then the fallopian tubes, if visible, possible hydrosalpinx, or because normally we don't see the tube, but if it is seen, it could be either a hydrosalpinx or filled with internal echoes, which can be either hematosalpinx or pyosalpinx, and any other abnormalities noted in the case of an adnexal mass. This is reported using IOTA terminology and definitions. And then about the presence of free fluid, the location of the fluid, whether there is free fluid in the pouch of Douglas, or whether it's extending to the utrovesical fold or to the adnexal region, and the amount of fluid they must have shown in the earlier picture how it is demo measured. And then ascitic fluid, when it is outside the pouch of Douglas, we call it as ascites. And then appearance could represent whether it is anechoic fluid, or then you could relate it with recent ovulation, or be echoic with low level internal echoes, or clots, if there are some echogenic or low level internal echoes with clots, is in keeping with blood or pus. Relating to the clinical scenario, we have to highlight these features. So if a large pelvic mass is noted, always we should do a transabdominal scan, or is a must, because transvaginal has a limited depth resolution, so we cannot assess the true nature. So one has to complement transabdominal to transvaginal, and that should be performed and to fully assess the true size of the lesion. And if a gynecological malignancy is suspected, it's good practice to complete a full upper abdominal survey. Say the kidneys should be looked for, especially if there is any dilatation or hydronephrotic change in the kidney, or even when we look at the uterine anomaly, one has to always look for any associated renal anomalies, and then look for the liver, spleen, and peritoneum can be looked for in case of malignancy, to look for any evidence of spread if the sonologist is qualified to do so, or refer to a specialist. So the report should be concluded and the conclusion should be succinct, should be more precise, and report abnormal findings with likely diagnosis, or when there is possibility of alternative diagnosis, a differential diagnosis can be entertained, and could also suggest further what investigation would be ideal for the patient, and also the management, like in case of ectopic, or when we suspect a polyp, or so we can suggest them to do a sonohistro or to instill fluid to get the true nature of the lesion, or a hysteroscopic approach. So here are a few examples. Here, this is a 37-year-old lady, para 2, normal vaginal delivery, irregular vaginal bleeding for the last 3 months with a negative urine pregnancy test. The uterus is anteverted, echogenic focus seen with the feeding vessel, normal appearance of both ovaries, no masses of free fluid seen. Conclusion is ultrasound findings demonstrate an echogenic focus within the uterus with the feeding vessel. So when we look at this report, the uterus size is not described, and the focus, echogenic focus, is not defined as where it was exactly seen. And the normal appearance of ovaries is reported, but what is the dimensions, what are the 3 orthogonal measurements of the ovaries are not given. And coming to the conclusion, the echogenic focus within the uterus with the feeder vessel. So that is not, they have not come to a conclusion. So here, the concise style, it is yes. No ambiguous terminology has been used. No inappropriate technical language. No irrelevant information irrelevant information is avoided. Limitation stated, no. Addresses the clinical question, no, because the patient came with bleeding, abnormal bleeding. Then abbreviations used carefully, no abbreviations. And then conclusive where possible, no final conclusion was there. Is this an accurate report? Absolutely no. So no measurement was given for any of the structure and doesn't give a differential diagnosis too. This is the second example. 53-year-old lady, post-menopausal, abdominal pain and bloating, previous hysterectomy. So the uterus is absent. Hysterectomy is noted. Normal left ovary, right ovary contains a complex mass, no free fluid in the pelvis. Conclusion, complex mass in the right ovary, suggested referral to the gynecology rapid access clinic. So the hysterectomy status has been denoted, but the normal left ovary, the size is not given, and the right ovary shows a mass. The nature of the mass and the size of the mass is not defined. Also, the vascular pattern is not defined. So the nature of the lesion is not being highlighted in the conclusion. So the concise style. So the checklist is concise style. Yes, it's very concise. No ambiguous terminology. No inappropriate technical language. And irrelevant information is avoided. Limitation stated. Not. Addresses the clinical question. Yes, the patient complained of bloating of abdomen. So they noted a mass which is arising from the ovary. Abbreviations used carefully. Yes, no abbreviation. And conclusive where possible, no conclusion. So this is an accurate report. It's not an accurate report. So no measurement is given for the ovaries or the mass seen and doesn't give a differential diagnosis too. So this is the third example where we see the, 53-year-old post-menopausal, abdominal pain and bloating, previous hysterectomy. So this is the report which should be precise, well written. The following the guidelines, transvaginal, by what route it is performed with verbal consent. So one need to get a verbal consent before the transvaginal is being performed. Good views obtained. The uterus is absent due to post-hysterectomy status. The left ovary is visible. Measuring the dimensions are given, and the ovary is mobile and appears quiescent. That is compatible with her post-menopausal status. And right ovary contains a smooth multilocular lesion, which is 10 into the dimensions are given with anechoic content. So that means no solid lesion and no crescent sign is visible. The lesion is mobile and non-tender. So the iota color score 1 which tells there is no vascularity and no free fluid is seen within the pelvis. So final conclusion would be smooth and avascular multilocular mass in the right ovary, and so suggested referral to a gynecology rapid access clinic. So the concise style of that report, yes, no ambiguous terminology, yes, no inappropriate technical language, no irrelevant information, limitation stated, addresses the clinical question, yes, abbreviations used carefully, yes, conclusive where possible, yes. So this is an accurate report. So that's how following the guidelines, one need to do a precise, concise gynecology report, and the final report should conclude or answer the clinical question which we are facing with. Thank you.
Thank you, ma'am, for this concise, chronological and logical reporting style for a gynecological ultrasound report. There are a few questions for you, ma'am.
Yes.
Which software do you use to report both OBS and gynae ultrasound, Sonocare or Astria?
Sonocare.
Could you please explain the sliding sign?
Sliding sign is like you introduce the transvaginal probe, and then the focus to the region of interest. If you're going to look at the ovary, you want to see for the fixity of the ovary, you try to focus the probe head towards that ovary, and then slightly apply pressure at that site, so abdominally, and then apply slight pressure, and from below you need to give little pressure towards that ovary. So like push-pull technique. When you do that, naturally you would be seeing the ovary, if it is freely mobile, if it is freely mobile, you'll be able to see the ovary and the adjacent, either the uterus, if you're seeing in close relation, they'll be sliding again in the opposite direction, but it will be moving in the opposite direction. But if the uterus and ovary is adherent, the whole thing will be moving together. That is how it will appear if it is sliding sign negative.
Right.
Nita ma'am, is it possible for you to show that video? Is it there in your PPT right now?
In my PPT,
they have requested if it's possible to show us a video of the sliding sign.
I think it was in yesterday's Mala's lecture, not in today's.
Never mind. It's okay, ma'am. Yeah.
Yeah, might be I can show. 1 second. In that endometrium, 1 second.
Yes, ma'am.
If they'll be able to appreciate, I'll just show that. See, as it is being introduced, no, you can see the surrounding structures. They are free, they are sliding against, but this is not very good. See here, the bowel is moving free of this uterus, whereas if there is adherence, you will not be seeing the free sliding of the uterus. That's one. It's not very evidently shown in this picture.
Yeah, it's not very clear, ma'am.
Yeah.
But the attendees can view yesterday's recording, which
exactly.
which is available for you all, so you can see the video there.
I think Dr. Shabnam's as well as Dr. Mala's slide shows about the sliding sign.
Yes, the recordings are available. They can view in the recording.
Right. Ma'am, how to confirm post-op collection in a uterine scar area?
Scar area, obviously, at the level of the isthmus, we do see if there is any heterogeneity of the myometrium. Then that is when you suspect, or when there is any irregularity in the contour of the serosa of the uterus. then we do suspect if there is any anechoic, heterogeneous or any fluid with internal echoes, focal collection is there, then we do suspect.
Right. Ma'am, how do we diagnose a isthmocele or a niche?
Isthmocele
Yeah.
on ultrasound.
Yes, ma'am.
Isthmocele, you'll be seeing a communication which is extending from the cavity into the anterior myometrium at the level of the scar area, a track extending into, and that's how we suspect the isthmocele.
Right. Ma'am, in case a sonologist has done a scan in a gynecologist hospital and hasn't signed, so can a gynecologist sign for the radiologist?
I think the person who does the ultrasound has to, first of all, write the report, and they take the responsibility to sign the report also.
Okay. Ma'am, what is a crescent sign?
I think that Dr. Mala must have explained yesterday whether the lesion is adherent to the ovary or it is separate from the ovary. Right. So that is where the crescent sign helps us to differentiate.
Right. Can a gynecologist do a gynec ultrasound, or is any certificate required for doing an ultrasound?
I think anybody who's going to perform need to have a proper ultrasound training, so that they'll be able to do a systematic examination. Yes, any.
Right. What are the normal dimension of a premenopausal ovary?
Premenopausal ovary, there are various normograms available in the, you can just refer, that is in a premenopausal, that also varies with the ethnicity. So we can always refer the charts for that.
Right. Okay.
And I think yesterday Dr. Mala had shown in her presentation the normal size of the ovaries in a reproductive age group as well as the postmenopausal, like where the volume will be, its ovarian volume would be around 4 to 10 ml in case of reproductive age group, and 0 to 4 ml the volume would be in case of a postmenopausal age group.
Right, right. So ma'am, that is all that we have for the questions. Thank you so much for answering all the questions, and a wonderful lecture, ma'am. It was really very precise and concise, and has given us all the insight on how to write and how not to write a report in a gynae ultrasound. With this, we come to the end of the course with the final lecture. And now we move on to the valedictory function. I would like to invite Dr. Vaidehi ma'am to give us a brief about this course and the journey of this course that we had.
Yeah, thank you so much, Amor. Respected dignitaries, respected Dr. Suresh, and my dear trainees. I really feel honored to welcome you back to the concluding valedictory session of the ISUOG Ultrasound BT course conducted by Mediscan Systems Chennai and Nagpur OBGYN Society. It's the most sought after course, which was proved by the tremendous response you all have given for the course. I was informed, and I'm very happy to share with you all once again that this is the highest ever attendance ISUOG has had for the BT course till now. Dr. Suresh has been our guiding force, and he has been helping us at each and every step. We are very, very happy that we could be a very small part in his mission to spread knowledge to each and every doctor practicing ultrasound. No wonder he is the Mahaguru of ultrasound in India, and we are very happy that he could join us for the valedictory today, in spite of being stuck in something very important. Dear friends, this course has been our dream project at Nagpur Society, and I'm very satisfied today that this dream has come true and we could very successfully take it forward, and as many as 600 doctors were benefited. We've got a tremendous feedback from all of you, and thanks for informing us that you have found this course very useful and it was excellent. Thank you so much. My heartfelt thanks to Dr. Jihad, the chairperson of BT course ISUOG, and ISUOG team for allowing us to conduct this course. Profound thanks to the entire faculty today for accepting our invitation and being there, answering each and every question so patiently, and the question and answer sessions have been extensive, but you all have been so patient with all of us. Your knowledge and experience in the field will be deeply valued for a long time to come. The biggest gratitude goes out to Dr. Suresh sir. I have really never ever seen a teacher who's so supreme yet so humble. Sir, we have so much to learn from you, and no words are really enough to thank you, sir. I also take this opportunity to thank my very hardworking team who have put in their 100% 24 by 7 to make this event a grand success. Last but not the least, thank you, dear attendees, who you all of you have enrolled in such a large numbers. This really wasn't possible without your active participation. Friends, we have sent you an email with a feedback form. It's our request to you to please fill it and send it back to us, because this will be really useful in conducting future courses and will help us to improve us. Signing off from the basic course for now, hoping to see you all very, very soon. Thank you.
Thank you so much, ma'am, for this beautiful elucidation and summarizing the entire course. Uh, Now we're moving ahead with acknowledging all the people who have been a part and made this course successful. So, kindly, I'd like to kindly direct your attention to this video. Thank you so much for viewing this video. I would like to request Dr. Suresh sir to please speak some words of wisdom to the for departing graduates that will be soon graduating from this course.
Good evening. Thank you very much for me being asked to be part of this course. First of all, I should say Vaidhi has been continuously saying things about me, but the truth is it is her persistence and perseverance which brought us to this level. We've been discussing about this for more than a year now, and twice we tried to fix the dates, postponed, had a tough time getting dates from ISUOG, and we were at the very last minute. We had to postpone it by a week before we could get it done. But all is well that ends well, and it has shaped up quite well. Now, I thank all of you who were enthusiastic about the course, and the best thing I found about it is a huge number of questions which have come, and most of the questions were extremely relevant, and that shows that you had put your thought into the lecture, and then the doubts have emerged from that, and that I think is a certain thing which is the object any teaching program. When it generates questions, it means understanding is already better. Now, I hope and pray that you will utilize this training very effectively in a practical way. And if you have any doubts, you can go back for a month on the videos, recorded videos, listen to it again, so that till your practice becomes a standard practice as has been described. The whole objective of this course is to standardize, standardize, and standardize. That's all. Many of you would have been doing ultrasound already for many years, but even though one of the ways is to realign your thought process of things which you already know, but you realign it in a systematic fashion. That is the objective. Now, I have to thank also Mr. Ekambram of Mindray. When I approached him regarding sponsorship, they were their budgeting was very meager, was not available. Then he stood in for us, spoke to the highest authorities of the company, and ensured that funding was given for this so we could effectively do this. From my ISUOG team, Catherine Smith has been extraordinary help. She's always responded. But I know how busy she was, and even though with her extraordinary busyness, she managed to find time and then do this for us. And that is because they are also committed to PT training across the world. Now, in India, we have taken it upon ourselves to be the country with the largest number of BP trainings. And that's the journey we have embarked on. So we will do this course once more a little later. And hopefully people who have not yet joined will be able to join, get themselves aligned with this course. So ultimately the idea is if a large number of people get trained on the standard training, then when everybody generates reports, when patients go from one doctor to the other, one sonologist to the other, when they find the report, they know the report format, then the clinician is able to accept that report very well. They understand the images very well because everybody has been exposed to it. So this is the fundamental objective of doing this over and over again. So my other faculty who have been quite extraordinary, especially Titya Cohen. Titya Cohen we keep on sharing information at the background about the evaluation, assessment, training, and all that. So she's been a great guiding force because she was one of the key people who initiated this PT course. And several of the modules she developed. And she also runs an outreach program in Oman, which is very, very popular. So as a master teacher herself. Reem, of course, is the head of the meeting till Jihad took over. And the way she drove us, putting this course together for 2 years almost, was quite extraordinary. So, you've all done very well, and I'm very, very happy that you all came and participated. And of course, learning does not stop here. ISUOG is going to come out with an advanced course very soon. The modules are being prepared, and hopefully that we should get benefited from that also. So thank you once again. Thank you, Vaidhi, for giving me this opportunity to be part of this course. And Nagpur OG Society, my hats off to you for the extraordinary persistence, perseverance, and the smooth conduct. The audio-visual team.
Conference.
Conference has been outstanding. There is not a single glitch. went through it so beautifully, patiently did everything that is needed, uh, guided every presenter into what they need. That was quite extraordinary. So we can, India can boast of audio visual strengths, teaching strengths, subjects. We should be leaders in the world. So we are the leaders. So all of you enjoy yourselves now. You've got freedom from this course now. At last.
We are
3
feeling
hours,
sad, sir.
3 hours a day, 3 hours a day for 2 days a week, up to 10 o'clock, until extending till 11 o'clock. That is something people will say, okay, next Thursday, let's go for dinner. That's what they'll say. Thank you all. Have a great day. Bye.
Thank you. Thank you so much, sir. Your words of appreciation and encouragement really mean a lot to all of us at Nagpur Society, sir. But really, I am repeating again and again, it wasn't possible had it been not you with us right from the beginning. You've been pushing me, encouraging me, supporting me at each and every step. And the entire team at Nagpur has supported me to take this forward. So thank you so much, sir. It's not been 3 hours every day. It's been more than 4.5 hours every session. And you are the reason behind it, sir. You have encouraged me. You have told me extend the session by half an hour. All each and every question should be answered. So this speaks so high about you and your passion for teaching and dedication for the course, sir. Thank you. Thank you so much, sir.
Thank you. Bye.
Bye bye, sir.
Bye.
Thank you so much.
Bye.
Take care, sir.
Bye.
Thank you so much. Now it's time to bid an adieu, farewell. But before we do that, there are certain people we need to thank. So I, Dr. ISUOG Course, on behalf of NOGS and ISUOG, will bid you a farewell. But even in this difficult and dark time of COVID, waxing and waning over the entire year, and more than that, there was a beautiful silver lining to this situation. And that started with the inception of the ISUOG basic training in OBGY ultrasound to be conducted online, so that doctors all over the country could benefit from the comfort of their homes and hospitals and improve their skills and ultimately serve the society in a better way. It has been a beautiful journey which started from the first week of Feb and was almost akin to a pregnancy. Today, we are almost near term and ready to be delivered. So why do I say it is like a pregnancy? Like any couple planning a pregnancy, we advise them to start with prenatal supplements and plan their pregnancy accordingly. In the same fashion, I would like to thank the course director, Dr. Jihad Chaluhi, for this wonderful course program, for the training and supplementing us with those well-needed prenatal vitamins. I would also like to thank the gurus of Guru, Dr. Suresh sir, the ambassador of ISUOG from India, for taking out time for teaching us in so much detail and explaining even the smallest and the trivial of doubts raised by the delegates. It is very rare to get a teacher such as you, sir. Thank you once again, Dr. Suresh sir. Now, the first trimester of pregnancy is a very crucial one, and we may face which we may face that are faced by the mother. We do face a few problems in the beginning of the course, may it be for the registration of the course or getting enrolled after payment and logging in. These first trimesters issues and glitches were solved to the best of their abilities by the technical support team of ISUOG. A very special mention for Ms. Catherine Smith, who was very prompt and efficient to solve all the queries and doubts regarding the registration process. And so we entered into the second trimester, that is the lecture session. Many of us had many questions regarding the obstetric ultrasound, right from how to hold a probe to the various steps in completing an obstetric and gynecological evaluation. All these doubts were expertly and diligently answered by the eminent international and the national faculties. I would like to mention and acknowledge the sincere effort and the time that has been put in by the international faculty as well as the national faculty, including Dr. Kitya Cohen, Dr. Reem Abu Rustam, Dr. Shabnam Bobriwala, Dr. Mala Sibbal, Dr. Usha Sahadevan, Dr. Chitra Andrew, Dr. Divya Singh, and Dr. Sudarshan Suresh. Without this esteemed panel of experts managing our second trimester, we would have definitely landed in PIH or surely GDL. Entering into the last trimester, that is, gaining all the knowledge from the gurus, which was possible because of two very important cogs of the machinery. Our education partner Mindray, who graciously agreed to see this program through and supporting us in all the aspects of this course. The second one being the conference and its technical support team, who managed the whole screening and streaming as well as recording of this elaborative training course and lend their support whenever it was required. We once again thank Mindray and Conference from the bottom of our hearts for ensuring a smooth and zabardast streaming of this conference. And now it's time to thank the most important entity of this entire certification course, the baby, that is you, yes, you, the delegates, who have grown from a small gestational sac to a full-term baby, tiding over all the tests and scans and the investigations, learning the dual the anomaly scans and the entire scanning in the obstetric as well as gynecology, and constantly challenging the faculty, the mother, with questions and queries to grow into a healthy baby ready to be delivered. But wait, there is still time for delivery, and to decide the date of the delivery, we'll have to wait till all of you receive the instructions by email by ISUOG, confirming the dates of the certification program, and you will all be receiving it by 11th of April. And this email will contain all the steps of how to log in, how to give the exam, and it will also include the revision page to look at in the meantime. The exam process includes three attempts, and in any one of the attempts, you must score more than 70% or more to successfully complete this course and certification program. As ISUOG members, you will have access to the ongoing access to the ISUOG learning platform, where you can explore the online activities and earn CPD points. As always, if you have any questions or problems, you are more than welcome to contact education@isuog.org or ksmith@isuog.org for help in technical issues. So finally, I would like to thank the entire organizing committee of NOGS, the coordinators from NOGS who made it possible to get all the delegates registered for this wonderful course. And now, finally, I would like to say goodbye, adieu, farewell, sayonara, and see you all again in the advanced training course. Signing off, Dr. Amok Chimote. Thank you very much.
Oh, great. Thiru?